Okay. Give everybody just a few minutes to get in. Good morning. Good morning. How are you? Great.
How are you?
Fantastic.
Good morning.
Good morning. Good morning. I think most of us are here. I didn't hear anybody join our live session. Good morning. Okay. Where's it, Rebecca? Good. Any questions on your homework? You have chapter 4 over the in between classes. I know chapter 4 is a bit weighty. There's a lot there. But you aren't responsible for knowing what diseases affect what body systems or what body systems are made up of, which organs belong where. You're not required to know all that. That's not really what CNAs do. You are required to know what's normal as we age, because older adults are not like young adults or middle-aged adults. They just aren't. They're different. It's like kids. They look like mini humans, but they're totally different, right? They have different normal values, different things you have to think about, different ways of treating. So as CNAs, we're going to work more with the older population. That's where most of our time will be centered. And sure, you may be taking care of young or middle-aged adults somewhere in there as well. Some of you may specialize in pediatrics, and you get some additional training regarding that. But for the most part, what we really have to focus on is older adults, because that's where the biggest need is. That's the biggest patient population we have to work with. So you do need to understand what's normal as we age, because if you don't understand that that's normal, it's really hard for you to pick up abnormal. And remember, that's what we have to report. Does that make sense? Okay. So chapter 4, I know it's kind of long and you got to slog through it. There's a lot there, but you're not really required to know all of that. Problem is, I kind of have to put it in there so that you can get a foundation so you can learn those abnormals. So I know it's a little bit difficult. All right, so let's see how you did on 4. I'm going to get your scores. So it's going to be on page 135 of your white book. Selenia. Thank you. Olivia. Thank you, Fa. Thank you, Kat. Thank you, Ray. Thank you, Millie. Thank you, Sierra. Thank you, Rachel. Okay, Rachel, do you have 1, 2, and 3 for me? Somehow I missed those. So it's going to be page 132, 133, 134. If not, I can get it from yours. Yeah. Okay, thank you. And Millie, do you have chapter 3? Thank you. Thank you very much. All right. Does anybody have any questions on anything that you missed on that chapter? Any questions? All right. So we covered a lot of information on Monday, a lot of content. Did anyone go home and practice blood pressure? Okay. All right. Are you starting to feel a little more comfortable with it? Kind of dialing it in a little. Yeah, remember I said it takes about 45 blood pressures before you really start to get it. Right now, you probably feel like you need one more hand to make it work right. Yeah, if I had one more hand, this would be perfect, right? And that's normal. That is normal. Forgetting what you're listening for, that's normal. That first one is kind of hard, especially if your brain is the kind of brain that goes out and picks daisies when there's nothing going on, right? Because it's quiet, it's quiet, it's quiet, it's quiet. I'm hungry. I wonder if Taco Bell Maybe I should get Taco Bell for lunch. Thump, no, thump. I don't really want fast food, thump. Oh crap, where did it start, right? So it's really easy for your brain to get distracted when it's quiet. Some of you will also have trouble on the first one because you've got some self-esteem issues, and this is common too. You inflate, you deflate, it's quiet, 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 nothing happening. Oh my gosh, I missed it. I don't know what I'm doing. And you quit listening. The show hasn't started yet. Don't walk out of the theater, right? Just keep listening. It'll show up. But those actually aren't as common as having trouble with the last thump, because the last thump doesn't really tell you it's there. You don't know that that one was the last one until nothing else shows up. So it's really hard to catch that last one, especially if you're rhythm oriented. Now my rhythm people, right? If I put a rhythm together here, you'll start to anticipate that next one. And our heart is pretty rhythmic, right? So you kind of get into the rhythm. You anticipate when the next one's going to show up. How many of you guys filled in that next beat? If you're the rhythm person, you're going to have trouble with that last one because your brain is going to get into the rhythm and fill in a beat for you. And you're not sure, oh my gosh, was that a thump or did my brain make one up? So you really have to train your brain to pay attention to each one of those thumps. Okay, 82, 78, 74, 70. 70. That was my last one, 70. So you're waiting for that next one to come. When it doesn't come, then that means the one before it was the last one. Okay, this is why it takes about 45 blood pressures before you start to really dial it in. You guys are right exactly where you need to be. Don't put the pressure on yourselves. Okay, you don't need to be perfect at this right now. But you do want to get it down. And the only way to get it down, honestly, is practice. I can't really help you perfect that. I can teach you how to do it and encourage you to practice. But at this point, it's really up to you. Okay, does that make sense? But don't shy away from this because it's hard. This one really is the hardest skill we do. Blood pressure is hands down the hardest skill there is. And that's because it's taking eye, hand, and ear coordination. And all of that has to be coordinated by the brain. So you got 4 organs involved here, and that's a lot. So it does take some time to learn. But don't give up on it just because it's hard. I might be the body in the bed one day, and I need you to be accurate. Okay. All right. So blood pressure took a lot of time on Monday. We also learned mouth care. You guys remember brushing teeth? We also learned range of motion, hip, knee, and ankle. And we also learned hand and nail care, which was our first washing skill. So we had to learn washing rules as well. We're going to get into some other washing skills today. So today is going to be a repeat of a lot that I said on Monday. So if you missed it Monday, you're in the right place. You're going to hear it again. We're going to learn foot care, which is hand and nail care just on the foot with a small twist. Remember with hand and nail care, we had to file the nails to keep them short. You guys remember that? And we soaked the hand, washed the hand, rinsed the hand, dried the hand, cleaned under the nails, filed the edges, put lotion on. That was hand care. Well, we're going to do the same thing on the foot, but we're not doing anything with the nails. So we don't trim them. Remember, nail clippers are not used by CNAs. We don't file them. We don't clean under them. We don't do anything with toenails except for look at them. And that's really the whole reason that you're doing this skill. It's not to get the foot clean. It's really not. Well, we'll clean the foot while we're there. It kind of gives us an excuse to look at the foot. We're going to clean it while it's there. But cleaning is not why you're doing this. You're doing this to have an excuse to take the shoe off and the sock off and look at every surface of that skin to make sure there's nothing strange going on that needs to be addressed. Because feet are usually hidden. They're in socks, they're in shoes. We don't see them. And if we don't see them, that means that things may be going on there that aren't getting caught. And I've got a story to explain why this would be important. So we'll get to that in a few minutes. We're also going to learn another range of motion. So all of the rules that we learned last week and reviewed on Monday, we'll review again, another range of motion. And then we got two new skills, totally new. One of them is assisting residents with bedpan, and the other one is supported sideline position. So bedpan is actually not a hard skill. And in fact, the most important step of bedpan has nothing to do with bedpan at all. So I'll get to that in a few minutes. Sideline position is simply turning somebody over onto their side and using pillows to prop them in that position so they don't fall back. So I've got a lot to explain to you about both of those skills. So that's kind of where we're going today. Any questions on our plan, what we're covering? All right, so let's start with bedpan. Go ahead and open your books to page 106. And yes, we will get to the state task registration today as well. All right, so if you read the care plan at the top of the page on 106, because everything starts with the care plan. So we're going to read the care plan at the top of page 106. And that care plan says the resident has requested a bedpan. The resident is not wearing undergarments and is able to wipe self. The resident is able to move as directed. So this is somebody that for some reason is stuck in a bed. They can't get out of bed. They need a bedpan. We're going to help them with that. But I want you to pay attention to where it says they're not wearing undergarments and they're able to wipe themselves. Because if you look at the bottom of the page, you'll see that this is going to be done on a live person, one of you. Now, everybody's freaking out right now. Wait a minute. Hold up. What do you mean I'm not wearing undergarments? It's not that kind of a test. I didn't sign up for that. So for the test, this is written in a very specific way on purpose. If you are the patient for the test, you are going to remain fully clothed. Do not take anything off. We are going to put a gown on over your clothing, a hospital gown. So it's going to appear as if you're in a hospital gown, but you're still remaining fully dressed. The reason that that is there is because we don't want the person doing the skill to try to pull your clothes off. We want you to remain fully clothed. Okay. So if that wasn't in the care plan, somebody may try to help you undress, which we don't want. So that's why it's in the care plan, because the evaluator can point to that care plan and say, stop. The care plan says they're not wearing undergarments. So nobody's trying to, undress you. The other thing that that care plan says is the patient is able to wipe themselves. We don't want anyone all up in your personal space. So for the test, nobody's going to be wiping you or cleaning you, or even with clothes on. That's a little too invasive. So pay attention to this care plan. It is super important. You're not going to help somebody take their clothes off. You are not going to clean them up after. Okay. So all we're really doing here is putting a bedpan under them and taking it away. I mean, not hard. There's not actually going to be anything in the bedpan when we take it away either, because they're fully clothed. They're not actively using it. But there's a couple things we have to talk about when it comes to bedpan. Even though the skill is easy, bedpan under, bedpan out, clean it the same way we clean everything else. We have to talk about the bedpan itself. So if you go back to page 105, we're going to talk about this. So do you remember how this works in a clinical setting? The nurse has to go in, do a full assessment, head to toe, real problems and potential problems, right? And remember, nurses have to assess patients every single shift. So this isn't a one and done because patients change. Every shift, the patients need to be assessed. Well, one of the things that's high on my list is toileting, because I know everybody's going to have to go. At least once during my shift, you're going to have to go to the bathroom. So I got to figure out how we're going to make that happen. Ideally, just like you'll get up and go whenever you need to, and we're not involved. That is nice. We like that. That is called bathroom privileges. And it's often abbreviated BRP, bathroom privileges. That means that we aren't involved. You're just going to go when you feel the urge, just like every other competent adult in the world. You don't need us. But not all patients are going to have that level of ability. So you may see bathroom privileges, remember BRP, with assist. So that means, yeah, they can still go to the bathroom and take care of their things, but they need a little help. Maybe they need help walking, maybe they need help disrobing, maybe they need help cleaning, maybe they need help pulling their pants back up. I mean, whatever they need help with, that's where that assist comes in. Good. So bathroom privileges, that's the one we like. We're not involved. Bathroom with assist, they're still going to the bathroom, we're just helping. If they can't make it to the bathroom, though, we got to come up with plan B. 90% of the time, you want your patients in the bathroom. That's where this stuff normally happens. It's normal. Patients don't have a problem with it. That's ideal, but not always practical. If the patient can't make it all the way to the bathroom, well, we have a portable toilet. It's called a bedside commode. You'll see it over there in the corner. That is a bedside commode, abbreviated BSC, bedside commode. And we can actually bring this right to the side of the bed. And that toileting order would be BSC, bedside commode. I mean, take it out of bed, they sit on the commode, they do what they need to do, and it's up to us to empty it, clean it, keep it clean. We can do that. You might have a BSC with assist. That means they're using a bedside commode. We're just having to help transfer them or help them with some aspect of it. Okay. But those two things are ideal: bathroom or bedside commode. Bathroom number one, because that's normal. Bedside commode close second, because it approximates a normal elimination process. You're still sitting on something that feels like a toilet. Let you go. Anything other than that, we're going to run into problems. So bathroom, bedside commode, two top choices. If we can't use those two, we're going to run into problems. So now I'm left with three possible scenarios. If we can't get to the bathroom and we can't get onto a bedside commode, the first question I'm going to ask myself as a nurse is this patient even continent? Are they aware of their need to go, and can they control that? Are they continent? If they're not continent, well, this conversation is kind of moot anyway, because they can't control it. So they're just going to go when they need to go. We'll clean them up. That's pericare. Incontinent care, we're going to get to that next week. But if they are continent, now I only have two choices left. Either they get a catheter, and man, that has a lot of risks to it. A lot of risks. I don't want to use a catheter if I don't absolutely positively have no other choice. So my last option here is a bedpan. Bedpan, that's it. Notice it was last on the list. I had to get through all that other stuff before I got to bedpan. We didn't start there. I had to go through all those other options. Can they get to the bathroom with or without assist? Can they use a bedside commode with or without assist? Are they incontinent? Do they have a catheter? No crap. All I'm left with is a bedpan. Because bedpans are a problem. They're a serious problem. because you've been trained from the time you were this tall, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. Oh my gosh. These lessons that are taught to you at a very, very young age, they stick. And they stick big time. So just because I put a plastic pan under your butt doesn't mean your brain is going to let you pee in the bed. You see how that would be a problem for the patient? So when you're helping somebody with a bedpan, it's very, very common for you to get a bedpan under them and they can't go. So you take it out, 20 minutes later, they hit the call light saying, oh my gosh, I got to go. I got to go. I got to go. You put a bedpan under them, you leave them, they can't go. Take the bedpan out, 20 minutes later, they hit the call light. I got to go. I got to go. I got to go. You hit a bedpan underneath them. And they might be able to go a little bit, but not a lot. And then we're doing this all day long because their brain won't let them go in bed. This is even worse with bowel movements. Patients that use bedpans are often constipated because their brain just won't let them go. Now, if your brain cooperates, okay, if you can get your brain on board, and you talk your brain into, hey, listen, one-time thing, there's a fan there, it's all right, just go, it's all right. If you get your brain on board, now you've got a reflex issue because the bedpan, your bedpan's only that deep. Now, when you go to the toilet, you got quite a bit more depth between your bottom and the bottom of the holder, right? The toilet bowl. This, you don't have that much space. And where this is all happening is right in here. Do you see how shallow that is? Because this is between the legs, guys. You see how shallow that is? That means when you pee, you're going to get splashback. Guys, liquid under pressure, hitting a flat surface, you're going to get splashback. So when you get splashback, your body's going to clench. It's a reflex. So even if you were able to go a little bit, now we got a problem. So do you see why bedpans are a problem? Right? This is a hard thing for a patient. Very hard. The other thing is they're just not comfortable. They are not comfortable. This goes under the butt. It looks like a toilet seat, so that's where the butt sits. But this isn't comfortable for anybody. So we've got uncomfortable, in bed, splashback. I mean, this is just not ideal, right? Okay, so we're going to talk about that right now. Very good. So the number one step for bedpan has nothing to do with the bedpan at all. The number one step you're going to be graded on has everything to do with the position, just like Kat said. So we have a body laying in bed, and we put a bedpan under them, and we need them laying down to put that. You know how hard it is to try to get something under somebody when they're sitting on their butt? They can't lift their butt up. Try lifting your butt up. Don't use your feet. Don't use your hands. Lift your butt up. Yeah. Yeah, it's kind of hard, right? So we need them laying down so they can use their feet on the bed for leverage. They can bend their knees, put their feet flat on the bed, and lift their hips up. We need them in a laying position. So we put the bedpan under them, but if we leave them in this position, how many of you ladies can pee uphill? Look at what this did to this person's middle. It raised the middle up. You are trying to pee uphill now. This is not effective at all. And if by some miracle the patient can push some pee out, it's going to run right up their back and into their hair. I don't know about you, but that's really high on my gross meter, right? So when you put a bedpan under the patient, the single most important step is to get them into a sitting position. So the number one step for bedpan has nothing to do with the bedpan. It has everything to do with the head of the bed. You've got to elevate the head of the bed. You've got to get them sitting up. They can't pee laying down, and they certainly can't poop laying down. You need some gravity there, okay? But if they're sitting on the bedpan, we got the same problem. We can't take it out with somebody sitting on it. The head of the bed has to go back down so you can get that bedpan out. Good. Now this care plan tells us the patient can move as directed. Yay! Because that means the patient can lift their hips. You can get the bedpan super easy. But what if the patient can't? In a clinical setting, what if you're working with a patient that can't lift their hips? In that case, you're going to roll the patient to the side, put the bedpan against the bottom, and roll them back onto that bedpan. When they're done, hold the bedpan flat and let them roll off of it so you can take it out. Don't let the bedpan flip because that would be a mess. So has everybody got it? Now, with all of this moving of the head of the bed and the patient and all of that, whatever's in that bedpan is going to slosh and it'll probably spill. So what's something that we might be able to put on the bed, cover the sheet with, to keep those sheets dry? Something that's maybe waterproof and absorbent. A barrier, chalks, yeah, absolutely. So this skill, you're going to put a barrier under the patient, a chucks. You're going to put the bedpan on top of that. You're going to put the head of the bed up and make sure the patient is comfortable. When they're done, you'll put the head of the bed back down and you're going to take that chucks and bedpan out all at once because you have to take that bedpan over to the bathroom. You should never, ever, ever carry an open container of human waste anywhere. That's just, first of all, it's a privacy violation. Nobody needs to see what's in there. Okay, that's a privacy violation. But it's also an infection control problem because if your shoelaces come untied and you trip, you're going face first into that bedpan. Yeah. So you have to cover that bedpan with the chucks. So you're going to take the whole thing out, chucks and bedpan, cover the bedpan with that chucks, and take it over to the bathroom for disposal. You do need to take a quick glance at it. You need to see, is it normal? Because we can tell a lot about the health of the patient by what they're eliminating. Is the urine cloudy and foul smelling? That's something that needs to be reported. Is the urine purple? That's something that needs to be reported. And yes, that is a thing. Yeah, there's a medication that can turn the urine purple. But bacterial infections can also turn it green. Blood can turn it red. Dehydration can turn it brown. We got all different kinds of colors going on. So if it's not light yellow or golden amber and clear, you got to report it, right? Same thing with stool. If stool is red, that means the patient may have some internal bleeding. If the stool is yellow, they may have C. diff. If the stool is green, a lot of problems there. A lot of problems there. So you want to make sure that the nurse knows anything that you notice that's a little abnormal. If you're like, that looks funky. Even if you can't put your finger on it, I'm not sure why. It just doesn't look right. Don't throw it away. Cover it, leave it in the bathroom, and go get the nurse and have them take a look at it. The worst thing you can do is say, oh yeah, patient so-and-so used the bedpan and it looked funky. And she'll say, okay, where is it? Oh, well, I flushed it. Okay. Funky is not, that doesn't help me. Funky, that doesn't help me. Don't just flush it and then tell the nurse something was wrong with it. They need to be able to assess it. Okay. And remember, patients pee several times a day, but generally don't defecate several times a day. So we may lose an opportunity for another 24 to 36 hours before we can take a look at it. That's a long time for something to be happening in the human body unchecked. Good? Does that make sense? Okay, so you put the patient laying down, you put the chucks under the patient, the bedpan under the patient, head of the bed up. You're going to give them a call light and toilet paper because remember our care plan said they could wipe themselves. So give them the toilet paper to do that. When they're done, they're going to say, I'm done, or they'll say beep, beep, or they'll say call light, something like that, let you know they're done. You're going to come in, put the head of the bed down. You're going to take the chucks and the bedpan out and take it over there to the bathroom, dump it out, clean the basin the way we clean everything else. We're simply going to rinse it, dump the rinse water in the toilet, dry it, store it. So all of that, that's bed. That's everything you need to know for bedpan, but we're going to go a little bit further because there's a few things that I want you to know outside of the test. So remember I said with our bedpan that you get splashback? You guys remember that? That's going to be very uncomfortable for the patient. So when you're helping somebody with bedpan, there's two questions you want to ask the nurse. Remember, bedpans are not all that common. We had to go through that whole list to get to bedpan, right? So they're not common. If you've got a patient using a bedpan, you need to ask the nurse two questions. Number one, can I use toilet paper in the bedpan? And number two, can I put powder on the bedpan? Because if you put toilet paper inside the bedpan, just take toilet paper, big loops, 5, 6, 7 big loops, and you lay it in the bottom of the bedpan, it prevents that sloshing because the toilet paper absorbs the urine. And it also will prevent that splashback effect. So the patient ultimately stays a little drier, a little more comfortable. Good. But if we're measuring the urine, we can't put toilet paper in there. It also affects your ability to really visualize the urine, right? Because you can't really tell if it's clear if it's all in the toilet paper. So you have to ask the nurse, can I use toilet paper with that patient? The other question you want to ask is, can I put powder on the bedpan? Because this is plastic. Do you guys remember what temperature bodies are? Anybody remember? Yeah, 98.6 hot, 98-degree hot, hot. You put a hot butt on a plastic surface, it's going to stick every time. Wear shorts in a car with leather seats in summer. Your legs stick to that seat. So if you put powder on here, just a small sprinkling of powder, it prevents the bedpan from sticking. And sticking bedpans are really hard to remove. You got to use some force. And if you're using force with liquid, now you're wearing whatever they put in there. So powder is helpful. But if your patient has a wound or an incision or a respiratory condition, we cannot powder the bedpan. Remember, these are situations that you cannot assess. You have to ask, can I use powder on the bedpan? Can I put toilet paper in it? And if the answer is yes, do your happy dance, because that makes a bedpan so much easier for the patient and easier for you. But it's just not something you can automatically do because it depends on the patient. Good? Makes sense? All right. So now at the bottom of that page, I think you're on 105, you'll see what looks like a toilet seat. You guys see that? In a clinical setting, this is a clinical toilet. In a clinical setting, we have something called bedpan cleaners. Looks like a little shower head, stands up all the time. When you bend that forward, it pivots. When you pivot it forward over the toilet bowl, it will start spraying, and that is a bedpan cleaner. You can, right there, right on top of the toilet, you can clean this out, dump it right in the toilet. You don't have to worry about the sink. It is super convenient. The problem is that you have pressurized water hitting a plastic surface, so you're going to get splashback. So you got to dress for the job. They're very convenient to clean, especially when you're working with fecal matter. Very convenient, but you have to be prepared for it. You need to cover your uniform. Remember, you're going to be going in and out of other patients' rooms. You don't want fecal matter all over your uniform. So you want to cover it with a yellow isolation gown, one of those disposable gowns. Just throw it on over what you're wearing. When you're done, take it off, throw it away. You also want to cover all the holes in your face. You don't want that stuff splashing here. So use a mask with a shield. Just cover your holes so you don't get stuff splashing in it. You know there's going to be splashback here. So if you're using a bedpan cleaner, make sure you're dressed for the job. Okay. But it is much better to use a bedpan cleaner than to try to clean fecal matter out the sink, you know, because you don't want to dump the rinse water in the sink. People are going to brush their teeth there, wash their hands there. So you got to rinse it out, go to the toilet, dump it in, and you got to do that several times to get it clean. Bedpan cleaners are much more effective. Good. You won't have those in every setting though. You won't. Hospitals will have them. Rehabs usually have them. Nursing homes, it's hit or miss. It depends on how much money they had when they were constructing it, really. If it's a low-income nursing home, you don't have one. Bedpans are always kept in the bottom drawer. So the way these drawers are set up, stocked, is that everything grooming related goes on top. Toothbrushes, denture brushes, hair brushes, you know, anything grooming related. So think here, right? Anything bathing goes in the middle. Think here, bathing. Anything toileting goes in the bottom, toileting. So your drawers are set up in a very specific way. You don't want toileting items on top of grooming items. Ugh. Right. Pretty gross. So those drawers are set up in a very specific way, and that's exactly how they're set up for the test as well. Good. Does anybody have any questions? All right, so go back to page 106. Let's look at that care plan one more time. It says your patient has requested to use a bedpan. Patient can move as directed. Patient's not wearing undergarments and can wipe self. So there's one more step to this. Because it says they can wipe self. When you go to the bathroom, you should be washing your hands when you leave the bathroom because you wiped yourself. You took care of those bodily functions. So if your patient's stuck in bed, they can't get to a sink. So we need to remember, they wiped, they can't get to the sink, so I need to bring them something to clean their hands with. So you're going to give them a hand wipe to clean their hands after using the bedpan. Okay. Generally speaking, 9 times out of 10, your patient will put the toilet paper right down in the bedpan. Okay. When they wipe, they just drop it in the bedpan. If you're measuring the urine, you can't have that. So if you're measuring the urine, you need to make sure there's a trash can right there for them to be able to put the toilet paper in it, and remind them, please don't put the toilet paper in the bedpan. Put it here instead. You can also get, a lot of times we have these little paper bags. You can get a little paper bag to put the toilet tissue in as well. If they put the toilet tissue in the trash can, please make sure you bag up that trash and take it out of the room. Don't leave used toilet paper in a trash can right next to the bed. Right? So that means the trash has to be bagged up and removed. Good. I walked into a nursing home a couple months ago, walked into a patient's room, and this patient was bedbound, and they had chucks and adult briefs that they used because they were incontinent. And right next to the patient's bed was a overbed table with a food tray, right next to the bed, like here. Food tray, uncovered, ready to eat. Right next to the overbed table and food was a trash can overflowing with soiled chucks and briefs. You think that patient was able to eat? So when you're delivering food trays, look around, guys. You know, would you want to eat in that kind of environment? So, you know, just take a minute to make sure that these toileting situations are not interfering with other things that your patient has to do. Man, if I was a family member and walked in and saw that, that's unacceptable. That is unacceptable. We can do better than that. I don't care how busy you are. Back up the trash. Yes, yes. Men will use a urinal in bed. It looks like a little milk jug, right? They'll use a urinal and they'll set it on the overbed table because there's nowhere else to put it. They'll set it there, and that's where people eat. And it's if you see that, empty it. Get it off of the table, wipe the table down. Don't just leave it there for like days. Horrible. Huh? Oh yeah, absolutely. All right, so any questions? Okay, let me show you this video. I'm not putting anybody on a bedpan today. So I'm going to show you this video. And the reason I'm going to show you the video is because it has really good close-ups of all of these steps of putting the bedpan in place. I did a lot of camera angles for this particular video so that you could see exactly how this whole process works. Okay. If you'll notice, these videos were actually taped in this room. The beds were right there against that wall, and I had 2 sinks. So when we redid the room, I took one of the sinks out, so I had a little bit more room. But all of these videos are taped in this room. I'm getting ready to tape the new versions, and that's why I just have the lights installed, so we have better lighting. We're making this into a studio. One step at a time. Wonderful. My understanding you need a bed pan. Can I assist you with that? Sure. I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll need a Chucks and a privacy blanket for this skill. Okay, Mr. Jones, I'm going to place this privacy blanket over you. This will help keep you warm and protect your privacy as we do this skill. Is that okay? Yes. Okay. I'm going to spread this out without sounding it or shaking it. And I'll have you hold this in place. Start to pull your sheet down. That way your sheet remains clean as we do this skill. Okay, I'm going to prepare a chest to place under you. Before we put the bed pan in place. I'm going to hold the chunks up lengthwise and roll it toward me. Clean rolls toward me, dirty rolls away. And I'll just place this on the bed. I'm going to open the drawer that the bed ends in and get a set of gloves. Okay, just a moment. I'm going to ask you to bend your knees, lift your hips as high off the bed as you can, and I'm going to unroll the chucks underneath you. Okay? All right, go ahead, bend your knees and lift up. Okay, you can relax. I'm going to go around to the other side of the bed and unroll. Okay, Mr. Jones, can you lift up again, please? Just get the chucks out, making sure it's positioned properly on the bed. Relax. Okay, now I'll get the bed pan out, put it in the drawer. And I'm going to place this under your bottom, if I can get you to lift. And relax. Is that comfortable? Yes. Okay, I'm going to put the head of the bed up, but let me remove my gloves first. Okay. Okay, you're putting the bed up. Please tell me when you're comfortable. And you may have to adjust that bed pan a little bit as it moves.
Here's your toilet paper and your call light. And I'm just gonna wait out here. Please let me know when you're done. Okay, Mr. Jones, I understand you're finished. Let me help you with that. I'm gonna put the head of the bed down now. And please do not lift your hips. Once the head of the bed is in the lower position, I'll put on a pair of gloves. And I'm gonna position the bed pan flat as you lift off. Okay, Mr. Jones, I'm gonna take 4 of the trucks and pull the bed pan flat as you lift off of it. You can go ahead and lift on the number 3. 1, 2, 3. Thank you. I'll remove both the bed pan and the chucks and take them to the bathroom for disposal. I'll be right back. Once I get over here to the bathroom, I'm going to unwrap the bed pan and we'll throw the chucks away. Empty the contents of the bed pan into the toilet. And then I'll rinse the bed pan. We'll deposit the rinse water into the toilet as well. And then we'll set the bed pan down to dry. I'll pick it up with a paper towel. Dry the inside. We'll throw that paper towel away. We'll dry the outside. Throw that paper towel away. And get one for the drawer. Okay, I'm going to place the bed pan in the drawer. Along with the toilet paper. And we'll use the paper towel to close the drawer. Now I can remove my gloves. Wipe your hands. Thank you. Okay, you can relax your legs if you like. And I'm going to pull your sheet up and remove the privacy blanket. Want to make sure that we roll the blanket in a ball so that any scrambled edges don't contaminate other surfaces. There you go. Here's your call light. I'm going to go put this in dirty linen. I'll be right back. Okay, Mr. Jones, are you comfortable? Is there anything else I can get for you on here? Magazines, I got your call light is there. Please let me know if there's anything that we can do. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Any questions? Pretty easy. We're not going to turn this gear off. It's getting a little cold in here. I told you we only have 2 temperatures in this room. Hot and cold. Okay. No questions on bed pan? All right, we're going to skip sideline position for a moment. We're going to come back to that in just a few minutes, but I want to get to range of motion, elbow, and wrist. So we're going to go to page 55, please. Oops. Sorry, I'm wrong. Go to page 76. I forgot to tell you about this. This is why I have a syllabus to keep you straight. So we talked about toileting today. We talked about all the different ways that we can toilet. Bathroom privileges, bedside commode, incontinent, catheter, bed pan. There's only 5 real ways to go, okay? When you go into work, you're going to receive report from the people that are going off shift. So if you come on at 7 o'clock and you're going home at 7 o'clock, you've got to tell her about the patients. This is called shift report. And every place is going to do it just a little bit differently. Sometimes it's done in a nurse's station where everybody's all gathered around. Sometimes it's done in a break room behind closed doors. Sometimes we have what's called walking rounds, where you and the person that's going off shift go to each patient's bedside and information is exchanged. That way the off-going shift can introduce you to the patient. Every patient's or every setting is a little bit different. Okay. But there are things that you need to know about the patient that doesn't matter what setting you're in. And when you're getting report, it can be very easy to get sidetracked and to forget to relay something or forget to ask something, and then you're starting your shift, the other person's left and you don't really know what it is that you need to know. So instead of just having this haphazard, I'll tell you what I think you need to know type of process, there is something called the TEAMS report that's used by CNAs. This is only for CNAs. Nurses have a whole different structure. So this is CNA specific TEAMS report. Each one of those, TEAMS, stands for something you need to know about your patient. Remember that CNAs do ADLs, right? That's mainly what we do. We help patients with those routine tasks that they can't do themselves. Things like bathing, grooming, eating, toileting, you know, those types of things. That's the majority of what we do. So TEAMS is the order that we get the information. Remember, every patient has to go at some point during your shift, right? They're going to have to pee, they may have to poop, you're going to have to go. So the very first thing you need to know, T for toileting. You need to know how every single one of your patients toilets. That's number one on the list. Followed very closely by E for eating, because what goes out, we got to replace. Something's got to go in, and everybody's going to eat pretty much on every shift. So you need to know, are they on a special diet? Do they have to have their liquids thickened? Are they NPO, which is nothing by mouth? Now I'm going to stop there for a second because you're going, well, wait a minute. BRP was for bathroom privileges. BSC was for bedside commode. That makes sense, right? It's abbreviated English. NPO means nothing by mouth. That doesn't make sense. The words don't go together. Why? That's because the majority of medical abbreviations are not abbreviated English. They're abbreviated Latin. So if you're trying to make sense out of medical abbreviations, they may not make sense to you because you're trying to do it through an English brain, not a Latin brain. So NPO is nota per ora or nota per os, which is nothing by mouth. Okay, so keep that in mind. Well, primarily because Latin is the language of science. So way back in the 1500s, when science was just kind of really getting started, you had people in England and Germany and France that were all doing, Italy, that were all doing experiments, but they didn't really speak each other's language. But there was one language they all had to learn at university, and that was Latin. So it was the one language that they all had in common. So everything medical was always presented in Latin. Now, English has not become the main language of the world until about roughly 75 years ago. Medicine's been happening way longer than that. So that's why most abbreviations are going to be in Latin, not in English. Okay. And incidentally, do you guys know that English is not the #1 language in the world? Anybody know what the #1 language is? Spanish. That's right. So it actually doesn't really make sense to have everything in medicine abbreviated in English or Latin. It would make more sense for it to be in Spanish. But in America, we tend to forget that. Isn't that funny? I'm learning Spanish. I didn't realize just how complex it is. That's a hard language to learn. So T is for toileting, E is for eating. A is for the rest of the ADLs, bathing, dressing, grooming, all the ADLs. We do toileting special and we do eating special because those are the big two. ADLs is kind of everything else. M is going to be for mobility. Now, mobility has its own special category because it's important. If you've got somebody who is on bed rest, like that's their order, they can't get out of bed, and you don't know that, and you try to get them out of bed, there can be consequences to the patient. So mobility is always its own category. Are they on bed rest? Can they get out of bed to the chair? Do they walk with assist? Are they working with physical therapy? Do they need to be turned every 2 hours? There's a lot to cover under mobility. And then S is for special. Anything else that I need to know that wasn't covered, like vital signs every 4 hours. They have a procedure at 2. The family is not allowed in the room. It does happen. Families can sometimes be abusive. And sometimes the decision has to be made to only allow family visitation with supervision. That does happen. It's something that you would want to know during report. So if we have a very specialized way of presenting information, I can now give you report on patients very, very quickly. Room number 1 is an 82-year-old Black female with bathroom privileges. She is on a ADA 1200 calorie diet, no extra snacks. She is, her mobility is out of bed ad lib. She can, you know, get up and go anywhere she wants to out of bed ad lib. She's self-care on all of her ADLs, and you have to do vital signs every 2 hours around the clock on her. So that would be a report. That's a whole lot quicker than trying to go through all, you know, everything that has ever happened to her. That's just the information you need to do your job. So that's Teams report. But remember, Teams report always starts with toileting, because that is probably the most urgent need you're going to address. Good. Nursing has a whole different method of report because they got a lot of different stuff to go over. All right, so now you can go to page 55. All right, so on page 55, we have range of motion, elbow, and wrist, and we have done range of motion twice now. How do we know what to do with each patient? So what does this care plan tell us? Somebody read me the care plan. Somebody.
Provide the following range of motion exercise to the resident's right elbow and right wrist. Oh, sorry.
Okay.
Extension. Provide 3 repetitions of each exercise. The resident is not able to help with the exercise.
Okay, so what body part am I working on? Can I do the left one too while I'm there? No? Why? What if I think they need it? Okay. I have to follow the care plan, the whole care plan in? Nothing but that care plan. Now, I certainly can go to the nurse and say, hey, I'm doing range of motion on the right, like care plan says, but what about the left? They're not moving that either. If you've got a concern, you can take it to the nurse. Maybe they forgot to put it down. I don't know. It's possible. Remember, when nurses are writing care plans, they're getting interrupted by family, by CNAs, by doctors, by telephone calls, by lab results, by radiology, by surgery, who is canceling the next session. I mean, they're getting interrupted right and left. You think it's possible they might forget something now and then? Care plans are big. They're big. I mean, I have to know not just toileting, eating, mobility, ADL skills. I have to know way more than that. What brought the patient in? What are their chief complaints? What are their lab values? What do we have planned for them? What kind of consults do I have to get? I got to start thinking about discharge and they just got here. You know, there's so much there to consider on every single patient. And if I've got 10 patients, I mean, there's a lot going on in my brain, and it's possible that I may forget to tell you to brush their teeth. So if you got somebody who you know hasn't had mouth care and it's not on your care plan, probably a good thing to go to the nurse and say, hey, no mouth care. Dragon breath? You do something about that? And I may go, oh my gosh, I didn't put that on there. Hold on. Let me write that in. Yeah, they need mouth care. Okay. So work with your nurses. Remember, it's you and the nurse against whatever's trying to kill the patient. Make sure you're on the right team. If it's you versus the nurse, whatever's trying to kill the patient's going to win.
Should we ask them before we start the skill?
Yeah.
So that they won't be like, is it on there? Then no, you know, this.
And yeah, you may have nurses like that.
Mhm.
Yeah. If it's not on the care plan, I don't want you to do it. And you may have nurses like that. That's okay. Just
Ask before doing this.
Yeah.
Is there anything else? Was this all you wanted?
yeah, or just the right arm. Is that all I'm doing? And they may say, yeah, that's what care plan says. Okay, no problem. I'll take care of that. But the more professional you remain, if you've got a crappy nurse, the more professional they'll treat you. It's just the way it works. So if they're crappy to you, but you stay professional, you'll actually earn their respect and they'll stop treating you crappy. I don't know why. I don't. But that, I mean, literally kill them with kindness. It works. It works. It's like they just can't, nurses are a special breed, right? It's like they can't continue to be mean to you if you're nice. You will win them over. But it's all in your approach too. You know, if you're accusatory, you know, there's nothing on this care plan about the left arm. That may not go over so well. If you just say, hey, right arm only. Yeah, that's all I need. Cool, I'll take care of it. Two different types of conversations there. Does that make sense? Good. All right, so this skill tells us to do the right elbow and right wrist. Now we're only doing one exercise, flexion extension. And if you remember, that is up, down. So flexion extension of the elbow is this. The elbow is a hinge joint. It only goes one way. This is all you will ever get an elbow to do. If you get it to do something other than this, you broke it. Okay, this is it. That's all the elbow will ever do. So flexion extension appropriate. Now the wrist, however, can move in all different kinds of ways. The wrist can go up and down, no problem. But the wrist can also go side to side. It can also go around, right? So there's a lot of things that wrist can do. But our care plan specifies flexion extension, which we know is up, down. So this skill is the opening, elbow, up, down. Care plan says 3 times. Wrist, up, down. Care plan says 3 times. And the closing. That's it. That is the entire skill. I want this skill for the test. Now, I will tell you, whatever skill you dread, okay, you're going to have a skill that you dread. You're going to be like, oh my God, I really don't want that skill. I don't want that skill. That's the one you're going to get for the test. I've seen it time and time. I don't know how the cosmos does this, but the one skill that you dread is the one you're going to get for the test. So if you've got one that you truly don't like to do, you need to make sure that you're doing it often so it becomes second nature, because you will get that skill. You will. Now, if it were me, I would dread this one. Oh man, I really don't want range of motion elbow wrist. It doesn't give me a chance to show my true colors, my true potential. I don't want that one, right? I would dread this one. Okay. All right, so I need a volunteer. So I'm going to come lay down in the bed and I will show you what this looks like. I need you for like 15 seconds. This is quick and easy. All right, so this is my second skill. The evaluator told me I can simulate hand washing after my first skill. So this one I will do, simulating hand washing. Here we go. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some exercises on your right arm. Is that okay? I'm just going to close your curtain. Let me wash my hands and I'll be right back. I've washed my hands. I have hands. All right, Ms. Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bring your arm up and back down like you're making a muscle. So we'll turn your hand palm up and just relax. We're going to go up and all the way back down to start. Feel okay? Up and all the way back down to start. One more. Up and all the way back down. Good. Okay, so now I'm going to move on to the rest. We're going to go up and down like we're revving a motorcycle, and we'll do this 3 times. So I'm going to make a loose fist. We're going to go forward and back, and you should feel a stretch. Good. Forward and back. Any pain? Forward and back. Good. Is there anything else I can get for you on here? A magazine? Are you comfortable? Okay, here's your call light. This little blue button. If you need anything, I'll put it there and within reach. Environment is clean. Open the curtain. I have clean hands. I would mentally review my skills. So this is the gray box. So let's do this together. Did I do my opening? Did I exercise the correct extremity? The right side? Did I do flexion extension of the elbow? Flexion extension of the wrist? Did I repeat each one 3 times? Did I do my closing? I'm happy. My skill is done. Thank you. Good? Questions? So that's a good question. To answer that, go to page 56. And we'll do this together. So when you get your care plan set, one of these guys, they are going to tell you how much time you have to do that care plan set. So it's not per skill, it's for the entire set. So give me a number 1 to 11. 10. All right. So the computer randomly picked skill set 10 for us to perform. And the evaluator is going to read this to us and tell us we have 36 minutes to do this skill set. And we are measure recording pulse. We learned how to do that. We are performing passive range of motion to elbow and wrist. We learned how to do that. And we're going to provide a partial bed bath to a resident in bed. We're going to learn to do that. Okay. But the test is telling us we have 36 minutes to do those 3 skills. But the way that they figure that out follows a formula. So remember at the bottom of every single skills page that we've had, we've looked at how long it should take somebody with your level of experience to do that skill. Well, you can see on page 56, right there in the middle of the first column, you can see a graph that has all of those times in it. In the middle of the first column. You guys see that? So let's do this together. How much time do they say that somebody with your level of experience should be able to measure a pulse in? Okay, so if you've got a pen, write 5 in the along the edge of your page there. Okay, how much time should it take you to perform range of motion to elbow and wrist? 5 should be at the top. All range of motions should say. 4. Yeah, I thought it was 4. You see it? Okay. Now, provide partial bed bath. How much time would that take you? 19. So let's add that up. So we have 5 plus 4 plus 19. And if my math is strong, that gives us 28. But I told you you had 36. Where's the rest of that time? You're going to get 3 minutes for hand washing. above and beyond the time for the skill. So they're going to add in 3 minutes for hand washing. And then they're going to give you 5 minutes for thinking. They call it transition time. But that's time for you to review your skill, to think about your supplies, to make any corrections, to read the care plan. You got 5 minutes to do all this thinking, right? So if you add 3 to our 28 for hand washing and 5 for our thinking time, you come up with 36 minutes. So that's how much time you would have to do this skill set. Every single one of these skill sets has a time attached to it. If you go to page 17 in your book, I think it's 17, you'll see all of these care plan sets, and up in the corner, you'll see the time.
These are exactly how they're gonna come.
This, what you have on that page are these cards I'm holding right
And then when you take the test, they come in that same.
now. Same order. It is exact. What you have there is exactly the test. Exact. So how did I get that information? Well, 1,000 students that sat through my class came back and gave me their printouts from the test. And I compiled all that filing cabinet, the bottom drawer there is full of student evaluations, student test reviews. And I compiled all of that information to get this. It's over 1,000 students. I'm not going to have you there. These are up here. You can, because if you look at your syllabus starting next week, we have practice time built in. So during practice time, you can grab this, pick one, and practice it. You've also got them in your book, but we're not going to practice them per se because you're focused on the test, and that's appropriate. You got that test in your, your future. But for me, this really doesn't mean anything. This is one day out of your career. One day. Actually, realistically, it's 36 minutes out of your career. So practicing these skills in that order for 36 minutes out of your lifetime career, it really is kind of meaningless, right? I'd rather you know how to give a partial bed bath, how to measure a pulse, how to perform range of motion. Doesn't matter what order they're in. Doesn't matter which skills go with others. You got to know how to do them all. Does that make sense? So one thing I haven't told you guys, I haven't really talked much about, is that I do a live question and answer session every Thursday at 3 on my YouTube channel. And one of the questions I got last week was, I did a whole lesson last week on travel CNAs. So if you are interested in travel CNAs, you need to go back and watch that one because I talk about the pitfalls as well as the good parts about it. But one of the questions I got last week is, because of COVID, which skills aren't they doing? And I'll give you that information in a minute. I'll tell you what they're not testing on. But the point is that just because it may not show up on the test doesn't mean that you shouldn't be able to perform those skills, because the day after the test, when you go to work, you can't tell a patient, oh, I'm sorry, I can't clean your dentures. I didn't practice that one. It wasn't on the test. Right? So does it really matter what they're not testing you on? You should know them all. You should be proficient at all of them, not because they're going to be on a test, but because some patient, probably me, is going to need you to do that skill on them, and you got to know how to do it right. Right? But right now, as long as the mask mandate is in place, and this could go away tomorrow, guys, mask mandates are being lifted all over, everywhere. So this can go away tomorrow. But right now, with the mask mandate, they are not doing feeding, mouth care, or denture care because they can't test you without a mask. You can't take your mask off during testing. So right now, as of today, mouth care, denture care, and feeding are not being tested, but that doesn't mean that I don't want you to learn them. Okay. Can't tell a patient, I'm so sorry, I can't feed you. I didn't practice that because it wasn't on the test. Good luck. Good luck. Here, I'll place this nice beef stroganoff here so you can smell it. I'm just not going to feed you. Cruel, right? It's pretty cruel.
We also have to remember the supplies we need.
Oh, that's a good, very good question. Do you need to know the supplies? Yes, you do. Because as a nurse, I'm not going to say, I need you to go do a partial bed bath in room 16. And you're going to need a bath basin, 4 washcloths, 2 towels, soap, lotion, a barrier, a privacy blanket, and a clean gown. I'm not going to tell you that. I'm going to say, hey, go do a partial bed bath on room 16, and I assume you're going to know what you need. So yeah, you need to learn the supplies. Nobody's going to tell you what they are. You've got to learn them. And we're going to get to that a little bit later, but here's a shortcut, memory shortcut. If you're washing a small body part for the test, right? Remember hand and nail care, we just did 1 hand. Foot care, we're just going to do 1 foot. So for the test, if you're washing a small body part, it's 2 washcloths, 1 to wash, 1 to rinse. Everything else, 4 washcloths. Everything requires 1 towel, except for partial bed bath, because you need to cover the sheets. You need to protect the sheets. That would take 2 towels. Everything else is 1. So when you're talking about towels and washcloths, everything small takes 2, everything else takes 4. All skills take 1, partial bed bath takes 2. Okay. Other than that, try to make it make sense to you. Like mouth care. When you brush your teeth, what do you need? Toothbrush, toothpaste, water, somewhere to spit. Yeah, I want to dry my mouth off afterwards. So yeah, that's what you would need. And you need a place to put it. So I've got to create a clean space to put all those supplies. So what do I need? A barrier on the table. Those are your supplies for mouth care. Make it make sense to you.
And any supplies that we have, barriers on.
If you're using supplies, you should use a barrier. Now, bedpan is an exception. Because if you notice, I didn't put a barrier on the table for bedpan. I never used the table at all. Okay, you can. There's nothing in the test that says that you can't use this table. You can put a barrier on it. You can put all your supplies on it, just like every other skill. If you want to do that, that's perfectly okay. Me, personally, I have a problem with putting toileting items on an eating surface. Even with a barrier, it's still pretty gross to me. So I don't use the table. I leave the bedpan in the drawer until I'm ready for it. Perfectly acceptable. If you want to use a barrier and put everything on it, you can. That's okay. It's all right for the test. I don't like it personally. Okay. Does that make sense? There's one more skill that we're not going to use the barrier for, and we're going to get to that next week. So bedpan, you don't have, you can if you want to use barrier, but you don't have to because you don't have to use the table at all. But we are going to learn one more that doesn't require barrier a little while later. Okay. I told you I'm writing questions for the online program, right? That was a question I just wrote yesterday. What 2 skills do not require a barrier? Yeah, so that is in the online program, and you guys all have access to that. So there's right now over 1,200 questions. It's a lot of questions. A lot of questions. Between your book, the online program, the quizzes, and the practice tests, I have over 1,200 questions for you. You're going to be well prepared when you get to that test. Trust me. Everybody says my tests are harder than the state test. You're going to be well prepared. It's the skills you need to focus on. Okay. All right, let's go ahead and take your break before we get into the next skill. So come back in 15 minutes. Come back at 20 till, please.
Right? Well, I like the cold, but. I need to live in my-
It was getting a little bit. Not on a Monday when we're still about to sleep.
Right. So wake up a little bit.
Tired today. Tired because we have a state
Oh, Lord.
I'm gonna cancel tomorrow.
Oh, that's always a delight. That is probably the most stressful time.
I'm not back to sleep. Because I was on the foot all day, trying to make sure that.
Oh, I know what it's like on stage there. That's miserable.
And the problem was, I don't know what CNN, so she took a break.
Oh, when they don't come back on time.
Yes, and here we go, one of the residents on her wheelchair with her nightgown on. And luckily, these two states property, like facing the other way.
There's a lot of pressure on you.
No, and then I said, Miss Irene, can I test you out? Even I'm not allowed to.
Mhm.
Can I test you out?
At least put a blanket on.
I just.
That's the best thing you could do. Is put a blanket.
And good thing I was in the middle, with our supervisor. I said, can I cover you for a second? And then in case you let's go people and sleep. I'm thinking, so nervous. Try to cover somebody, but
Good luck.
because I feel bad if they went to school or this and then they get in trouble. So I said, okay, look at that.
Well, it's like the one question that I asked. You'll understand because you work in that setting.
Mhm.
You know, as the CNA, you see it. You have somebody, your co-line is over, say, where the mannequin is. Okay, so you're in that room. You're CNA, and especially if you work a night shift,
Mhm.
they have less staff. And you don't have your therapists, you don't have doctors there. It's just
Just you and.
you and
The
maybe
coordinator.
a coordinator.
Mhm.
They may have another CNA. It may just be the three of you
Mhm.
for 60 patients. And this happened not because I didn't work nights. They were cutting staff back. So you get the nurse and two CNAs, maybe say for 40 patients. That's all of you. So as a CNA, you're taking care of these 12, which might be on this hallway. Your team member is on this hallway, which may be in another direction.
Mhm.
The nurses are somewhere in the facility. And maybe do a into the catheter
Yeah.
or something, and the patient, like the mannequin, is having a seizure. There's no one around. You can't live that long. Getting the call, like, no one's going to see it.
We have that somebody working with mine.
Well, yeah,
Just like easy texting.
exactly. And that's usually what they do, but it's not gonna happen like very often. But what if it does? You don't have somebody like you can pick up the one phone and call. You have to deal with that, try to grab help.
Yeah,
And if the patients are sleeping, yes, it'll wake them up, you know, but still, if your nurse is in a room, your other CNA is on the other hallway, no one is going to hear you if you yell.
I actually yelled. Okay, I was working, right? And I saw this resident peeing in the bucket.
I've seen that happen.
And I said, and she's like this shaking. I said, oh God. So I went there, hold her, and so she don't fall. And then one of the things I said, I need your help. You're one of your residences. And then, what do you want? What do you want? And she ignored me. She went to the other room. She went to the other room. So I put the persons down, made a process, and then I said, I need you help. It was us, I told you. But you ignored me, you went to the other resident. And then after I yelled, somebody heard me, one of the coordinator, they saw her, the food in the bucket. And oh my God.
Oh yeah, I have that happen too. It's, and if you, like you said, sometimes if you're brand new as a CNA in the facility, they don't want to help you.
They don't want to help me.
And this is gonna sound really bad, okay, to anybody. But if you get a group of CNAs that are all one specific culture, they speak one specific language, and they get together and you are of that culture, or you don't
Yeah,
speak
you
that
like-
language, you're like the outside.
Outsider.
And if for some reason you make one of it, they all have their little groups and their cliques. If they don't like you, they're gonna make it miserable
But
for you.
actually,
They will not help.
a lot of people that I'm working with right now,
Mhm.
they actually see me that I'm not helping them. I'm not trying to. So now everybody can thank you for your help, thank you
Exactly.
for doing this. I
Mhm.
said, no problem. But if you necessary, then I'll show you that.
Yeah.
I'm not ducking.
Exactly.
But now they see me as a, yes. I used to work before, like I said, 27 years ago, it was different, really different. But now it's more strict. And then before we write only the
I earn the CNA's respect on those units, even though I was in social services, because of course everybody has to answer call-ins.
yeah,
But
and that's my
if
job.
if I'm going by and I see a call and I go in, somebody needs ignited because they're cold. They can't reach their truck. It's right there.
Yeah, I
They can't
do
reach
it.
it. I'm not sure
No,
CNA.
no, I can
I
do it.
can do it myself.
Yeah,
If
that's
I
me.
can do it with help, then I will. And by doing that,
Yeah. I actually do more than I was.
yeah,
But yesterday, I was interviewed her twice by the state. I was scared when she said, what you do here? I said, I'm a full like hospitality and I, give fresh water to the residents. Okay.
Oh, that's good.
And then she said to me again, oh, one of the residents went back and kicked off me. And then on my license, like it's very important. So me, I just watch for a slide, then I put it in the license. And that's why I was just good. Yeah, she didn't. Right?
I never understood this. I still don't. Still don't stay inside of it. All the operations, administrator, all the judges, everything. I just want to, everyone wants to see the incident reports and the resolutions to them. Which is how in our, well, we were in social services. Social services, we can report it, there's how they're not the nurses and we review. And we think about. They didn't have all of those together.
Miss Patricia, yesterday we have the state visitors,
Okay.
and one of the CNA, they asked her, do you know that this certain person don't realize she's a blind? And one of the CNA said, oh, I didn't know that. And then after that, she said that, I said, did you read the care plan? You gotta read the care plan, that's your job. And then it's like, she had no clue.
Yeah.
What happened? She said she didn't take, she just challenging the exam.
Right.
You better go to school. Because that's all the first thing that our teacher did the care plan.
The care plan, yeah. But it's amazing how many CNAs are out there working that have no idea that the care plan exists or that everybody is treated differently, that, every partial bed bath isn't going to be exactly the same, or every range of motion isn't exactly the same because they don't understand the importance of the care plan. Yeah.
She said she's challenging with someone. No, it's not enough.
Yep. And that's one of the reasons that I do what I do is to, even though people are challenging the exam, you can still have a good education in order to challenge, so that you're effective out there in the workforce. Yeah, I know, it's scary. All right, let's go to page 84. Foot care. This care plan tells us to provide foot care to 1 foot using soap and water, just 1. Even if the patient has 2, we're only washing 1. We don't care why. For the test, it's not even going to tell us which one you get to pick. Pick a foot, any foot, pick a foot. If somebody has something unusual going on, the evaluator may specify. Like if you're going to be the patient for this, okay, let's say that you get assigned to do foot care and she's going to be your patient, but you've got an ingrown toenail on your left foot. And you tell me, I've got an ingrown toenail. Then I'm going to tell you, make sure you're doing the right foot. Right? I'm not going to have you anywhere near that. Good. Okay. But I want to talk to you about why we're doing this. Foot care has absolutely nothing to do with getting the foot clean. It's why you're there. It kind of gives you an excuse to take the shoe and sock off. But that's not why you're doing this skill. You're doing this skill primarily to look at the foot, to visualize it, because feet are generally hidden. And I'm going to tell you a story that illustrates why this is so important. Many, many, many years ago, I was an agency nurse. Think of agency nurses like substitute nurses. You know how when you were in high school, your teacher couldn't come in, your normal teacher, they would have a sub who come in, right? And the sub would, they weren't doing much teaching. They were just kind of maintaining the class until your teacher could come back, right? Well, agency nurses are similar to that. We get called in when the regular nurses can't be there, can't show up. And we're there to just kind of maintain the status quo. Not my patient. I'm not making treatment decisions. I'm just there to, handle any problems, give medications, do treatments, just, kind of maintain. So I walked into this patient's room with a cup of pills, and the room itself was kind of dark. It just had that one small light above the bed, that one little fluorescent light. And this is a rehab center. So it's half of it is short-term rehab, like people aren't there any more than like 2.5 months, and then they go home or they go somewhere else. So this is where they get physical therapy and things like that, recover. And it also had a long-term care side, but I'm on the rehab side. So I go in, the guy's name is Henry, and I flipped on the light, and Henry starts yelling right away, turn it off, turn it off. Okay. So I turned the light off, walked up to the bed, and I said, hey, Henry, my name is Patty. I'm your nurse today. And is there a reason you don't want the light on? He says, yeah, I got diabetic retinopathy and the bright light hurts my eyes. I want it off. Okay, no problem. So I explained to him who I was. I've got your pills, and I'm kind of doing a little mini assessment on him, kind of figuring out, what his mutation is, and does he have anything going on, and all that kind of stuff. And as I'm standing there, I'm catching an odor. Now, if you've ever smelled a wound, they're very distinctive. And once you get into healthcare, you know a wound when you smell it, So I knew this guy had something brewing somewhere. So I asked him, Henry, I think you've got a wound somewhere. And I'm looking at my report sheet and there's nothing on there about wound care, about anything. So I said, I think you may have a wound brewing somewhere. Do you mind if I take a quick peek? Do what you got to do, he says. He was very gruff. Now this guy's only in his mid-50s. I mean, he was young, but he had lived kind of a hard life. He's one of those kind of gruff type of guys. So I turn him over. I look at all the usual suspects, the tips of the ears, the back of the head, the shoulder blades, the hip bones, the back of the legs. And I'm not seeing a whole lot. I get down to his feet and he's got those slipper socks on, the kind with the little dots on the bottom of it, the tread. And I said, Henry, I need to take your socks off for a second, look at your feet. And immediately he goes, no. Oh boy. That's exactly what I did. Why? Is there a reason you don't want your socks off, Henry? What's going on? He says, no, I've got neuropathy. And when you touch my feet, it hurts really bad. Leave them alone. So, okay, I found my culprit, right? I found my problem, because if he's telling me no, I know that he told the CNAs no. And the CNAs went, cool, and went off, doing the other things that CNAs have to do, and probably never told the nurse. So we have no idea how long this guy had gone with nobody looking at his feet. No idea. Well, now I definitely have to look. I mean, there's no doubt about it. So I turned up the charm, because you can always get further with patients by being nice than being mean, always. So I turned up the charm and I got him to let me take his socks off. And I got the right sock off. Foot was flaky. Definitely could have used a wash, maybe some lotion, but not bad. Tried to take the left sock off and it stuck to the bottom of his foot. Found it. Bingo. But I can't get the sock off to find out what I found. So I go get a big basin full of normal saline salt water and I warm it up and I put the whole foot, sock and all, in the basin. I go take care of some other patients, come back 10, 15 minutes later, take the foot out of the basin, and I tried to take the sock off. And when I did, I had to give it a little yank, a little, try to get it to dislodge. When I did, something flew off of his foot past my head. That is never a good sign. So now I'm counting toes. 1, 2, 3, 4, 5. They're all there. All right. What flew past my head? And I turned around and the floor was just like this. A little speckled floor. Baseboard was just like this. The wide plastic baseboard. This is the clinical setting looked just like this. And up next to the baseboard on the floor was one of those flat metal thumbtacks, the ones that are painted white. Nobody had seen it because the room was dark. And the white buttons on the bottom, the white dots on the bottom of the sock. Yeah, it blended in. Nobody saw it. Nobody knew it was there. Well, now what was left is we've got an area about this big around the bottom of his foot that's hard, black, dead tissue. Now, we've come a long way in medicine. We can heal a lot of things, but we can't bring stuff back from the dead. We're not Dr. Frankenstein. I mean, dead is dead. It's dead. And hard black means dead. It's dead. So I know this guy is in a really bad situation. So I take my pictures, I call the doctor, I call the family, I get the wound care orders, I call the wound care specialist, get all of my consultation, write up all my notes, document everything, and I go home. Not my patient, not my facility. But this guy stayed on my mind for a long time because this was really sad. And it was less than a year, but I don't know exactly how long. But several months later, I get assigned back as an agency nurse to that facility, but this time I'm on the long-term care side. And as I'm getting report, there's his name. So that tells me right there, he wasn't able to go home. He had to be transferred to the other side. This is now where he lives. This is sad. He's in his 50s. This is not what life was supposed to be like for him. So I go in and hi Henry, I'm Patty. I'm the nurse that found the wound on your foot. I'm on this side today. How are you doing? And he pulled the sheet back and he had to have a below the knee amputation. And I kind of figured that's probably what was going to end up happening. So this is tragic. I mean, this affected this man's life in so many ways. And what made it really tragic for me is that it was 100% preventable. Because if he had had shoes on his feet, where would the thumbtack be? Would not be in his foot. He would not have had an amputation. This is sad because it was 100% preventable. This man lost his foot for no reason. So that's a problem. And this scenario happens way more than you would think. How many of you guys have ever seen people walking around in slipper socks in the facility? How many of you have been the person walking around in slipper socks in the facility? I have. When I was patient in the hospital, I'd walk all over the hospital. Go down to Oak Hill, they have a Subway in Oak Hill. Go sit down at the table at Subway and you will see at least one patient going through the line at Subway in a hospital. And slipper socks, right? So, you know, we don't think anything of it in a hospital. You get those little slipper socks, the grippy ones, and that's what you wear. I mean, that's normal, right? But it's not normal. Do we use sharp objects in healthcare? Like a bank doesn't use very many sharp objects. Like I would feel much more comfortable walking around the floor of a bank because a dollar bill isn't going to stab me in the foot than I would walking around a hospital without shoes on, because a hospital has needles and scalpels and glass vials and even thumbtacks. But we wouldn't think at all about walking around in a bank without shoes. I mean, when I said that, you guys are like, of course you'd wear shoes in a bank. Why wouldn't you wear shoes in a bank? That's a much less threatening environment than the one that we let patients wander around in all the time in their shoes. But the real test is this. Would you let a child walk in a clinical setting without shoes? If you would not let a child walk in that setting, then why in the world are you letting patients? Slipper socks should never be normalized as appropriate for walking. Never. I don't care what you see. They're not appropriate. They're not enough. They do not protect against sharp intrusions. But now some of you in your brain, you're going, but wait a minute, wait. That story can't be real, because how does this guy have a thumbtack in the bottom of his feet and not feel it? I mean, really, how can that be real? Say it louder. The neuropathy. That's exactly it. If a patient has neuropathy, it's like static on the line. So we're hardwired. We are not wireless bodies, we're hardwired. We have physical nerves that transmit signals. So if I stub my toe, there is a nerve in my toe that the signal has to go through to join a nerve in my leg to get to my brain. So my brain goes, ow, that hurt, right? In diabetes, neuropathy puts static on that line. So now the signal can't make it from point A to point B. Neuropathy can best be described as, have you ever sat on your leg long enough it went to sleep? You know that pins and needles feeling when it first starts to wake up and you know how it hurts to touch it? That is neuropathy. That is what it feels like all the time. Doesn't go away. That pins and needles, ants crawling on you type of feeling. Doesn't ever go away. Yeah, it can. You can have episodes where it worsens and then diminishes. So if we have a patient with neuropathy, that means that if they have an injury, they may very likely not even realize that injury exists. That is why we do foot care. We do foot care to identify problems that the patient is not aware of because they can't feel that area. This also, not just diabetes, this also affects people with cardiac conditions because if your heart isn't pumping effectively, it can't push blood to all of the areas that the blood needs to go. So you have areas that suffer from hypoxia and tissue can die because of that. So a lot of our older patients are suffering from diabetes or heart disease. So we have a lot of really at-risk people. Now, if everybody's feet are always covered up in socks and shoes, how in the world would you know that there's a problem? That's why foot care exists. Good. But I want to spend just a few minutes talking about diabetes because over half of your patient population will be diabetic. Right now, ages 65 and up, this is just general population out there. I'm not talking about hospitalized people, just the people that are playing tennis in Timber Pines across the street. Okay. General population, over 40% of people over the age of 65 are diabetic. That number is increasing by 3 percentage points every year. That's crazy. 3 percentage points a year. Yeah, that means that in less than 30 years, 100% of our elderly population is going to be diabetic. That's crazy if that trend continues. So what is diabetes and why should we care? So I want to explain to you a 5th grade version of diabetes. So I'm really oversimplifying this. Understand that diabetes is way, 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 way more complex than I'm about to make it out. But I want you to have a general understanding and overview of what it is and how it affects the body. So 5th grade version of diabetes. When you eat carbs, what's an example of a carb? Okay, Pop-Tarts. What's that? Bread, pasta, rice, fruit, potatoes. Okay, so those are all carbs. And if you notice, most of them were white. We call it the rule of white. If it's white, you look at it closely, it could be a carb. If it's bread, pasta, potatoes, so cauliflower is the obvious exception here. But generally speaking, if it's white, it's probably a carb. So flour and anything made with flour, like Pop-Tarts. Sugar and anything made with sugar, those are carbs. So carbs hide in a lot of places. Ketchup has carbs in it, and you wouldn't think it. So remember, anything made with sugar or flour is going to be a carb. Now, carbs in our society get a bad rap. Carbs are not bad. Let me say that again. Carbs are not bad. They get a bad rap, but they're not bad. And that's because every cell in your body needs carbohydrates to live. When you eat those carbs, they break down into sugar in your body. That is the fuel for every cell. So every cell in your body needs sugar to run on. You eat carbs, breaks down into sugar, and now your cells are happy. The problem comes when we eat too many carbs, because carbs themselves, you can't excrete what you don't use. So that means that if you eat a lot of carbs, your cells are happy, they're well fed, but whatever's left over, whatever you didn't use by your cells, has nowhere to go. You can't get rid of it. You can't sweat it out. You can't pee it out. It doesn't go anywhere. So this sugar circulates in your system, round and round and round and round. Well, your body thinks to itself, okay, we got all this excess sugar. We got to do something with it. We can't just let it keep going right around. So let's put it in a storage unit. Just like Spring Hill is popping up with storage units all over the place. When you have too much stuff, you put it into a storage unit. These are your fat cells. So the sugar gets repackaged into little packets of glycogen that gets shoved in your fat cells, and it's going to be stored there. So if you ever run low on carbs later on, we can unpack the storage unit and have a ready source of energy for ourselves. Okay, so everybody good with that? All right, so that's half of the equation. You eat carbs, breaks down into sugar, sugar goes into the cells, they're happy. Anything we don't use, we have to store on board. Can't excrete it. The other half of the equation is that that sugar cannot enter your cells alone. Your cells are locked. They're locked. So when you eat carbs, it breaks down into sugar. That sugar goes into your bloodstream. That sugar cannot get into the cell by itself. It has to have a key to unlock the cell. That key is made in a factory in your body called the pancreas. Your pancreas produces insulin. So you eat carbs, the brain says, hey, carbs, pancreas, give us some insulin. Pancreas creates some keys. The keys go into the bloodstream, unlocks the cells, the sugar can go in. Good. So there are two types of diabetes you need to be aware of. Type 1, juvenile diabetes, means the pancreas doesn't work. No keys at all. Never has been, never will be. Factory is completely offline. So in type 1 diabetics, we generally give them insulin. So we have to bring insulin in from the outside. So we give them insulin shots or an insulin pump. Now, the other type of diabetes, this is the one that's way more common. This is adult onset type diabetes or type 2. We're going to get to why that happens in a minute. Okay. So you eat carbs, carbs break down into sugar, goes into the bloodstream, pancreas creates keys, puts those in the bloodstream, keys open the cell, sugar goes in, everybody's happy. Anything we don't use gets put into storage units. But eventually you run out of storage units. There just aren't anymore. We're not building anymore. So now this sugar is going round and round and round and round and round. So in a normal person with a normal functioning system, we eat carbs, create sugar, makes keys, everything goes into the cells it can, everything else goes into the fat cells. We just get overweight when we eat more carbs than we use. A lot of fat cells. But with adult onset diabetes, what happens is we overuse our pancreas to the point that it just doesn't want to perform anymore. So we had a working pancreas at one time. This isn't like juvenile diabetes. Remember, their factory didn't work from day one. Adult onset, we overuse our pancreas and wear it out. So now when we take in carbs, breaks down into sugar, we don't produce insulin or not enough insulin or the wrong kind of insulin. And the sugar doesn't get into the cell. So the end result is the same. We have a lot of sugar going round and round and round the system that we can't excrete and we can no longer store. Okay, so keep that visualization in mind. So how does this happen with adults? Well, this actually doesn't happen in adulthood. It starts in childhood. So let me know if this sounds familiar to any of you. Okay. 3-year-old child gets up 6 o'clock in the morning. Mom says, oh my Lord, it's too early. I'm not ready for this. Mom hands child a Pop-Tart, lays down on the couch. Hour or so later, mom's finally, coffee's kicking in. She gets up to give the child breakfast, which is usually a cereal of some kind, but children don't eat Raisin Bran, do they? What do children eat? Okay, so that Pop-Tart that we pacified the child with is carbs, sugar, carbs. So the pancreas had to produce insulin. We give the child a bowl of Fruity Pebbles, all carbs. The pancreas has to produce insulin. Mid-morning snack. We're a good mom, so we're going to give our patient or our child some fruit, right? So fruit breaks down into sugar. So the pancreas has to produce insulin. Lunchtime, hot dogs, macaroni, and cheese, which are carbs. So our pancreas has to produce insulin. Afternoon snack, probably a little Debbie something, which are carbs. So our pancreas has to produce insulin. Dinner time, let's make some spaghetti. And that is carbs. So our pancreas has to produce insulin. And then you have dessert, because you can't send a child to bed without dessert. And that's always either ice cream or cookies or something sweet. So those are carbs. And our pancreas has to produce insulin. So you start this at 2 or 3 years old. Carbs, 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 carbs. And we get used to that carb heavy diet. So we get into adolescence and we think it's perfectly normal to exist on cheeseburgers and French fries and pizza. And that's all carbs, which makes your pancreas produce insulin. We get into early adulthood and we start introducing some vegetables into our life. Like we'll eat a salad, but we'll make sure that it's drowned in lots of dressing, which brings all those carbs with it. Because, you know, the lettuce has to taste good if we're going to eat it. And then we're so happy with the fact that we ate a salad that we'll reward ourselves with some ice cream later, which are carbs. And then we get into middle adulthood and we get too tired to cook. So we start doing easy things like sandwiches, which are carbs. So by the time you get into adulthood and the doctor says, oh my gosh, you're diabetic, you're going, well, how did that happen? It happened because you overused your pancreas. Every meal you've ever had has put a demand on the pancreas to produce insulin. And at some point it just said, I'm out. I give up. Done. Not doing this anymore. And it quits working. And either it quits altogether and you don't make insulin, or it makes insulin, but it doesn't have all of the ingredients it needs. So your insulin is lacking in a specific factor and it's not effective. Does that make sense? So if you want to avoid this while you're young, one of the things that you can do is make sure that you're balancing your carb intake with protein. So if you're eating carbs, there's not, like I said, nothing wrong with carbs. So if you're eating carbs, make sure you're eating half as much protein as you're taking in carbs. So if you're going to eat that large McDonald's fries, which is about 60 grams of carbs, you probably should eat 30 grams of protein to go with it, which, by the way, is an entire chicken. You're probably not going to eat an entire thing of fries and an entire chicken. So in order to balance that out, you'll cut down on your carbs. It's an easy way to modify a diet. Just make sure you're eating half as much protein as carbs. And it's easy. It's an easy way to modify a diet. But let's talk about why we want to do that. Why do we want to avoid diabetes? I mean, they got lots of treatments out there now. It's not that bad, is it? So let's talk about diabetes. Remember I said you can't excrete sugar out of your system. It just goes round and round and round. Well, sugar is a crystal, just like this. See how this is sharp and jagged and it clumps together, right? So this is what lines the insides of your arteries. And because it's stiff, it keeps your arteries from being able to expand or contract. It also blocks the inside of the arteries, so not a lot of good blood can go through. So remember our hose analogy that we had with blood pressure, right? We have a hose hooked up to a faucet. We turn our water on, the hose expands. Turn the water off, the hose shrinks. You guys remember that? Okay. Well, if your hose is filled with gunk, it can't expand. That means that less water is going to get through and you're going to have high pressure in there, not because of the water, but because of the gunk. So diabetics tend to have high blood pressure because of all the gunk inside. But it gets worse because these are sharp, jagged things, right? That means that anything that's floating by might get tangled up in there or shredded by these crystals. So that means that your red blood cells can get shredded. That's what brings oxygen to different areas of your body. Your white blood cells can get shredded, which is what keeps you healthy. That those are your army of your body. And in there, in all of this gunk, you're probably going to capture some cholesterol, which looks like pizza cheese in your arteries. So that cholesterol is going to get all kind of gunked up in there. So your arteries get smaller and smaller and smaller and smaller. So if we have an injury that occurs, it's going to be really hard to get good blood flow to that area to heal it. So this is what your arteries look like when you're born. Oh, they're nice. I want these arteries again, right? They are wide open, able to, direct blood anywhere you need it. But after a couple of decades of this American diet, right, and we've had a little bit of sugar that's been circulating and doing its damage, our arteries start to get a little bit of a buildup. Not really noticeable too much, but you can see the walls are a little bit thicker and there's a little bit of buildup in there. We might be getting a little bit of higher blood pressure readings at the doctor with this. Now, if we don't change our ways and we don't figure out that this could lead to long-term problems, then in our 40s, we end up with something like this. You can see that about a quarter of the blood flow in this artery has been restricted. That means a quarter of your oxygen is being restricted. A quarter of your bodyguards are being kept from where they need to go. That's significant. Doesn't look like much, but when you think about the effects on the body, that can be significant. Now, if we still don't change our ways, then we end up with this. Now, what you need to understand is blood that isn't moving clots. Anytime blood slows or stops, it clots. What you see there is a blood clot. Now, in the brain, we call that a stroke. In the heart, we call it a heart attack. Anywhere else in the body, we call it bad news. This is very real. And this is what most of your patients are encountering. So it's important to understand what diabetes is. It's also important to understand where diabetes affects, right? Because on planet Earth, we have gravity. So that means that these crystals are heavy. This is heavy. These are heavy crystals. So gravity is going to pull these heavy crystals down to the lowest points on my body. So the lowest point of my upper body are my hands. The lowest point of my lower body, my feet. Hand care, foot care. It's there for a reason. Diabetics will tend to have more problems with their hands and their feet than other areas of their body. And these are areas that you probably don't pay much attention to. Feet are usually covered in socks and shoes. Hands, you might see them, but do you really look at your patient's hands on a regular basis? Probably not. That's where hand and nail care come in, and that's where foot care comes in. It's not about cleaning, guys. It's never been about cleaning. It's about looking for abnormalities that need to be addressed. Does that make sense? Good. But all is not lost. So one of the things that you need to understand about diabetics. Anybody know a diabetic? Okay. Okay. So diabetics crave sweets. You guys notice that? Man, M&Ms, Hershey Kisses, donuts, snack cakes, they crave sweets. And most people will tell diabetics, oh my gosh, don't you understand you're diabetic? Quit eating the sweets. What are you thinking? What are you doing? This is stupid. You're diabetic. Don't eat those. We lecture diabetics all the time, right? We think that they should know better. But let me ask you this. Have you guys ever gone 24 hours without food? At the end of the 24 hours, do you get hungry? Probably hungry. Like hungry. I'm hungry. Okay. Remember that cells need sugar. That is the fuel of the cell. They need sugar to live. Now, if we have sugar in the bloodstream, round, 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 and we have cells that are starving, they are dying, literally dying. And they see the sugar going round, 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 round. They're dying. But there's no way to get that sugar into the cell. They can see it. They know they need it, but they can't get it. You think those cells are going to get a little angry? The cells send up an SOS to the brain. Hello, we're dying here. Get us some fuel. So the brain looks in this little filing cabinet, says, quick fuel, quick fuel. What's quick fuel? Oh, we need sugar. The brain doesn't know there's already sugar in the system going round and round and round. Brain doesn't know it's not a sugar problem. It's a key problem. We don't have keys. We got lots of sugar. We don't have keys to get it into the cells. Brain doesn't know that. Brain looks in the filing cabinet, says cells are dying. We need sugar, triggers that craving. This is why diabetic patients crave sweets. Telling them all day long, you shouldn't eat that, doesn't do a thing. Their cells are dying. Their brain is reacting to a very real catastrophe that's happening on board. Telling them to ignore that is just ridiculous. Ridiculous. It's like telling a thirsty person you don't need to drink anything. It's ridiculous. Don't lecture them. What we need to do is figure out how to get this sugar that's already on board into the cells. Well, we need keys. Well, sometimes we can't get keys. Every single cell has a back door, though. This is what most people don't know. That cell needs a key for its front door, but the back door is opened with protein. This is why you should have at least half as much protein as carbs, because if we don't have enough keys to open the front door, the protein will open up the back door. So if you have a patient who's got those cravings, you see them eating handfuls of M&Ms, talk them into adding a protein in. How about an apple with some cheese? Peanut butter and graham crackers, a half of a tuna sandwich, protein with those carbs. If you can do that, those cravings reduce because now the cells are happy again. They're fed. And we're not just adding more sugar into the system to go round and round and round and cause more problems later. Does that make sense? So if you've got a diabetic patient who is craving sugar, do not yell at them. Do not lecture them. It doesn't do any good. They are reacting to a very real emergency. What you need to do is try to get them to integrate protein. And diabetics that have done this are very successful at managing their blood sugar levels because they understand that if I don't have enough keys, then I need to open the back door. Protein. Good? Questions? You guys have a little better understanding of diabetes now? And do you have an understanding of why most of our adult patients are going to have diabetes? It is a lifetime of eating decisions. It is not what they did last week. I promise you. Okay. Does that help? Okay.
If you really want to say that you know somebody or have met somebody that is a diabetic type 1 that has had many complications, that would be me. I was diagnosed with type 1 diabetic at the age of 12. Very brittle, which means at 12, you've got all your hormones going through. My body didn't recognize it. Most of my adult life, could never get it stabilized. It would do the exact opposite of what it was supposed to. Exercise would shoot it up instead of going down. So it would shoot up quick. Body puts up the adrenaline. 2 hours later, it was crashing. 05, this happens. Okay, normal blood sugars should be around 100, lower than 100. I got so sick from having so much sugar in my blood. When I walked, and I stress this, I walked into Citrus Memorial Hospital in Inverness, into the emergency room, vomiting uncontrollably, still conscious. When they did my glucose, it was over 1,300. Most people would have been dead at that. From that, I ended up having that blood pressure issues. I ended up getting what is called diabetic retinopathy. Blood pressure, the blood vessels behind my eyes popped. They took 1,000 laser blasts to seal and cauterize the blood vessel leaks in the back of my eyes, in my right eye, just shy of 300 in my left eye. Got that all taken care of. Visions, low, but I had a lot of problems, many surgeries. A couple of years later, it affected my kidneys. In 2009, I ended up having to have a kidney and a pancreas transplant because they weren't going to, it affected my kidney function. They wouldn't do just the kidneys because of the diabetes, which was the cause of it, part of the cause of it. So realistically, diabetes affects everything. Thank goodness I have not had any amputations, no serious body wounds that have not healed, but it can be very, very severe. And I'm being honest with you. It is, and I heard all the lectures. I heard it all. You'll never be a candidate for the insulin pump. You could never. This was in the early 80s. I had my transplant in 09, just shy of being 39. But so it's been 11 years, 12 this year, 13, and everything's going well. But it is very, very complex and it's very severe.
So knowing that, if we had her as a patient, knowing everything that she's gone through, would we want a wound on her foot to go unnoticed?
No.
Right, because she's already had to fight so many things that a wound on her foot might be the tipping point. It might be just more than her body can handle. So this is why what we do is so important. So important. And that just puts a real face to the problem. So foot care it's not a hard skill, guys. Our washing rules apply. We're going to use a barrier. I mean, all the same rules that we use. As long as you understand why you're doing this skill, it's to look at the foot. It's not about cleaning the foot, it's to look at the foot. So during the test, you actually need to say something like, I'm looking at the foot, or I'm inspecting all skin, or I don't see any abnormalities, or something to let those evaluators know that you understand why you're doing this, that it's not about cleaning. Now, part of the problem is that most of you guys are young and you're still bendy. You are not as bendy as you get older. So you can look at the bottom of your feet. You could probably, all of you could probably look at the bottom of your feet right now. But as you get older, you lose a lot of that flexibility. So when you're in your 50s or 60s, the bottom of your feet is like Siberia. It's like a far off land that you just can't access. So you really do need somebody that can look at the bottom of your feet for you. This isn't a pedicure. We're not, rubbing and scrubbing and trimming and painting and doing all those kinds of things. It's not what this is. I personally wish that they would let us use those little pedicure rolling stools, though. That would make this a lot easier for the test. They won't. You actually have to get down on the floor for this. You have to kneel on the floor. Remember I said that your uniform is not considered clean once you start work, right? So it's okay. You can kneel on the floor. Your uniform wasn't clean anyway. But if you want to put a barrier down and kneel on, you can do that too. Perfectly okay. There's no problem with that. Just make sure you pick it up at the end of the skill, throw it away. Our environment has to be clean, remember. But if you want to use a barrier to sit on, go ahead. If you don't want to use a barrier, that's fine too. No problem with that either. But let's review our washing rules, right? If I have to get water, I've done my opening, I got my barrier, I got my supplies, and now I'm going to fill my basin with water. So my hands were washed during the opening. So can I touch that faucet to get water? What do I need? Paper towel. I don't want to put gloves on yet, because remember, if I touch that faucet and then I'm using those gloves to wash the patient, I'm transferring whatever contaminants from that faucet onto the patient. So we're going to use a paper towel to turn the water on. And I'm going to check it with the inside of my wrist. What should it feel like? Warm, not hot, not cold, just warm, right? But is it enough that I check it, or does somebody else need to? The patient. So once I get the patient to say, yes, it's good, we're going to get started. Whatever I wash, I rinse. Whatever I rinse, I dry. So our rules apply. Try not to get your surface wet. So we're going to put a barrier on the floor so that we're not sloshing water onto the floor. But make sure you're, bringing that washcloth out really well. Don't let it be drippy. Try to keep your surface clean. And then if we're going to use lotion, we'll warm it up in our hands first, put it on, and then what do we have to do? Wipe off the excess. Yeah, don't forget that. We don't put lotion between the toes though, because lotion between the toes is going to hold in moisture, and it's already warm, dark there. So warm, dark, moist. Remember, we talked about that being the ideal breathing environment. We always want to look for warm, dark, moist and avoid it whenever possible. So no lotion between the toes. Lotion on the top and the bottom, the heel, that's all fine, just not between the toes. Wipe off the excess. And then we're going to put the sock and the shoe back on, clean up all of our stuff, and that's the skill. That's it. I do want to wear gloves for this because my rules are, if I could possibly touch ooey gooey, personal skin, or non-intact skin. Because I don't know if the bottom of the foot has any wounds, I can't see it yet. There's a maybe there. So we want to wear gloves. But the first thing those gloves should touch is the, what do you think? Patient. We want to keep our gloves clean for the patient. So the first thing those gloves should touch is the patient. So that kind of tells you where you're going to put gloves on in this skill. You're not going to do it when you get your supplies. You're not going to do it when you get your water. You're not going to do it when you're taking the shoe off. You're not going to do it when you put, when you get your washcloths ready. You're going to put your gloves on right before you touch the patient, right before you put the foot in the water. Okay. That keeps your gloves clean for the patient. Good. Questions? No? Okay. I know it's a lot of information to go over for one skill, I know, but I think it's very important that you understand diabetes because it's going to impact your practice in a very big way. So I'm going to show you the video for this one. I am not getting on the floor. I'm getting way too old for that. Somebody asked about supplies earlier today. You can go ahead and turn that off. You can, you do need to memorize your supplies, of course, and you can make flashcards. I would highly suggest get some index cards, put the name of the skill on one side, put the supplies on the other, and just keep going back and forth. I do have these flashcards up here for you guys. I mean, you can use these to copy if you want to, but it has the supplies and for each skill. If you want to buy them, they're next door, but they're always up here so you can copy them if you want. The information is also in your book.
Hi, Mr. Judge, my name is Patty. I'm your CNA today. How are you? Wonderful. I need you to cook here. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor. Right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm gonna get some water for washing. Okay, Mr. Jones, would you like to check the water temperature, make sure it's okay? You're good? Very good. I'm gonna set this here. And I'm gonna needle on the barrier. And apply my gloves. I roll up your pants leg. And lift your foot so I can remove yourself. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out. Making sure that your foot is wet. I'm gonna place your foot over here on the towel. And apply soap to the washcloth. Want to wash all surfaces of the foot. You'll lift your foot up, start to wash the bottom. And I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. I'll ensure all surfaces are dry thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. Pour the lotion in our hands. Apply lotion to all surfaces except between the toes. So it'll lift your foot. And we'll apply lotion to the bottom, as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and push your foot back on the barrier. And now I can reapply yourself. And we'll put your shoe back on. Just like put it in like these. base of that. Now I'll put the barrier. And verbal. Now I can remove my books. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here? Okay, your coal light is here. If you should need anything at all, please let me know. Can I get your magazine? I'm gonna open my coat and wash my hands. After washing my hands, I'll review the steps to my skill, make any corrections, and tell the evaluator my skill is set.
Replace the battery. I don't forget the battery. All right, any questions on foot care? Pretty easy, right? That one I really would dread just because you have to get down on the floor and get back up. All right. Questions on anything before we go on? You guys need another break? All right. Okay. All right, let's go to page 98. How do we know what to do with each patient? You guys starting to sing along now? All right, so this care plan says position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. Please note, it does not say the patient is immobile. It says they're unable to assist with turning. Don't turn this into something it's not. They just can't turn. Doesn't mean that they're comatose or unable to move at all. A lot of people make that, for some reason, a lot of people kind of go in that direction. But while we're on the subject, let's talk about immobile patients. If a patient is unable to move on their own, then our job is going to be changing their position every 2 hours around the clock. When I say around the clock, I mean 2 a.m., 4 a.m., 6 a.m., 8 a.m. They are not sleeping through the night. We are turning them on a regular schedule. Do not do them any favors and let them sleep through the night. You will actually injure them. So in order to understand this, I want you to take one of your hands, either one, and put it under your leg and sit on it for the next 2 minutes while I talk. So go ahead and sit on one of your hands and try not to move it. It's going to get pretty uncomfortable for you as I talk, but try not to move it. Try to stay in one position while I'm talking to you, because this is going to be important. When somebody is immobile, unable to move on their own, this affects all parts of their body. It affects their digestion, it affects their respiratory system, it affects their muscles, their nerves, their heart. Everything is affected by this. So it's not as simple as, oh, well, they're immobile. Everything is affected. And you actually experience this a little bit at night when you go to bed. So when you go to sleep, you toss and turn. You don't stay exactly in one place for the entire night. You're constantly moving and stretching and twitching and rolling and repositioning all night long. And the reason that you do that is because of pressure. Because of gravity on planet Earth, whatever surface is in contact with the bed is getting pulled down. And all of the weight on top of that is getting pulled through that point. So right now you're sitting on your hand and all of the pressure, all of your weight is being pulled down to that surface. And you're probably getting a little bit uncomfortable and probably want to pull your hand out. Not quite yet. You've got about 35 seconds to go. Now remember, this is only 2 minutes. Now, if that pressure is allowed to persist, if it's allowed to keep going, then the surface, so if this is the bottom surface, all of the weight is being pulled down through that here. This is going to compress my skin and my blood vessels And the muscles on top of those and the bone and everything else is going to press down. What this does is squish all of that. That means blood cannot move through those vessels. They're squished shut. What happens to blood when it doesn't move? It clots. So this can actually keep blood from getting to that whole area because of a clot that has formed. Areas that don't get oxygen, don't get good blood, what happens to them? They die. And the material, the skin surface itself will start to separate. So go ahead and pull your hand out and take a look at it. Look closely. Do you see color changes? Anybody see color changes? Do you see the pattern of the chair or your uniform on the fabric of your skin? Can you see the imprint? It was 2 minutes. How deep do you think those lines are going to get if that pressure remains in place for 24 hours? 2 minutes gave you lines. Over time, those lines are going to get deeper and deeper and deeper and deeper and deeper and eventually cut into the skin. That is a pressure sore. Your body doesn't want this to happen, which is why you fidget and move. And even sitting here in these chairs for 4 hours, you're not sitting in one position perfectly still. You're stretching your legs, you're tapping your feet, you're moving around. And that's all designed to get blood flow to those areas, to aid in circulation and prevent that muscle fatigue from setting in because of lack of oxygen. So movement is good. It's necessary. If you've got somebody who can't do those movements on their own, though, they are at serious risk, which means that we have to turn them every 2 hours around the clock. So your patient's going to start on their back. 2 hours later, they'll go to their right side. 2 hours later, back to their back. 2 hours later, left side. 2 hours later, back to their back. Right, back, left, back, right, back, left, back, 24 hours. Notice I never said stomach. Do not put an immobile patient on their stomach unless the care plan specifically instructs you to do so. Because part of being immobile may also mean that they lack the strength to pull themselves off their chest cavity in order to inflate their lungs. If you can't inflate your lungs, what happens? You die. Absolutely. This is why we tell new moms don't put babies on their tummies, because babies may not have the strength or the nerve innervation to lift off their chest cavity to inflate their lungs. Isn't that crazy? So unless the care plan specifically tells you immobile patients don't get put on their stomach. Now, remember, immobile means unable to move on their own. Don't make somebody immobile that's not. Okay, you can have a bedbound patient that's confined to bed but not immobile. You can have a COVID patient on a vent, but they're not necessarily immobile. They can still move their feet, they can still move their arms, they're not immobile. Don't assume that just because somebody is in bed that they can't move anything on their own. Those are two totally different scenarios. Does that make sense? Now, generally speaking, if you've got an immobile patient and you have to turn them every 2 hours, there's going to be a chart on the wall that will actually show you, from noon to 2, they should be on their back. From 2 to 4, they should be on their right side. From 4 to 6, they should be on their back. So there should be a chart on the wall that shows you where they should be. If there's not, make one. Perfectly within the CNA scope of practice to make a chart, put on the wall so everybody's on the same page. As a nurse, if I walk in, I should be able to look at that wall and figure out where the patient should be and make sure they are. That way I know that my CNAs are taking good care of that patient. Good. But this patient is not immobile. It just says they can't turn on their own. But it does ask us to help reposition them. Furthermore, it's going to tell us which side to put them on, their left side. So this is a problem that a lot of people struggle with. So I'm going to show you with her real quick. I'll show you what this means. So if I'm going to turn her onto her side, that means I only have two choices here. I either turn her toward me or away from me. That's it. So I want to show you something really quick with, can you just kind of move that table up really quick? So I want to show you something real quick with mannequin, because she's going to illustrate this really nicely for me. If I turn her on her side, she's not going to stay there because she's a big Barbie doll. If you've ever worked with a Barbie doll, played with a Barbie doll, you know they don't stay on their side. They always fall over, right? But they always fall over a certain way. So if I put her on her side, right, watch how she falls. They'll always fall onto their back. People too, because most of our weight is distributed along the back of our head, shoulders, back, hips, butt, and legs. Most of our weight is situated back here, and gravity will pull the patient back onto their back consistently. So that means that if I turn this patient toward me, and I know that gravity is trying to pull them back onto their back, and they start to roll that way, in order for me to help them to help break that roll, I've got to be way over here. And that is not safe, because if I fall, I'm going to fall on the patient. I actually have no leverage reaching that far away from me. So I'm not going to be able to break their fall, and I'm probably going to end up injuring them. So turning a patient towards you is bad body mechanics. Bad. But there's another reason why you should not turn patients toward you. If I turn this patient toward me, there's no easy way to say this, guys, but her face is now eye level with my crotch. If this patient has ever been a victim of a sexual assault, this is going to be a problem. Even though I'm a female, this is still going to be a problem. I may not have meant anything by this, but this is going to be a problem. Got it? So when you're turning a patient, remain behind the patient's behind. Always turn a patient away. Good. But the problem, let's keep going here. The problem with turning a patient away from me, you think that patient feels safe? Why? Yeah, they're close to the edge of the bed, right? So we talked a little bit about this last week. I told, Kat came and laid in the bed, and I said, look at where she's in the bed. She put herself in the middle, and I told you to remember that. It's going to be important. Today is what we're going to talk about. Okay? When you lay down in bed, you automatically put yourself in the middle of the bed. And you do that because you feel safe in the middle. Even if you're only there for a few seconds, you'll put yourself in the middle, because that's where you feel safest. We don't feel comfortable on the edge. Now, this, again, is a skill we learn when we're very, very young. Remember I said that skills you learn when you're young stick, right? So when you're a baby, you're put in a crib. It's trying to keep you safe. But somewhere around a year old, you learn this magic trick called escape the crib. And now all of a sudden that crib is not effective at keeping you corralled because you've learned how to get out of it, right? And you end up going over the rail of the crib and then dropping to the floor. And that's when injury can occur, because you're now trying to escape. So that crib isn't keeping you safe anymore, is it? So we take you out of the crib, we put you in a big girl or big boy bed, which is really low to the floor, small little bed, really low to the floor. So if you get out of that one, you're not going to get injured because it's low to the floor, and you learn how to sleep in a bed somewhere around 2 years old. Your body knows how to keep you safe in this space even when you're sleeping. So you can be dead to the world, snoozing, sawing logs, and you will still stay in the middle of the bed, even though you're tossing and turning and rolling and stretching and repositioning and all of that. You still stay in the bed. You don't fall out of it because a little piece of your brain is always awake. It's the part that's responsible for spatial awareness. So you don't have to tell somebody, stay in the middle of the bed. They already know that. They've been doing that themselves for years. So can I ask you to come over here and lay down in the bed for me real quick, just to show you something? Just lay on your back. Okay, so again, she put herself in the middle. All right, so can you roll that way so you're like facing that? Okay, I told her to roll. She didn't roll. What did she do?
Oh, I intend to be staying in the middle.
Ah, that's right. You shifted your weight so that at the end of the roll, you were in the middle. Now, why, even though I told her to roll, why wouldn't she want to just roll? Yeah, she would feel unsafe. She's going to feel like she can fall off the bed. That's right. So your patients automatically have this ability. You don't need side rails to keep somebody safe. Side rails, just like a crib, do not keep people safe. In fact, it increases the risk of injury because they're going to go over those side rails. People do not like to be corralled. You just don't. Thank you very much for demonstrating that. So if your patient will always position themselves in the middle of the bed, even if they're on their side, they'll shift their bottom as they turn so that their bottom is still in the middle, just facing a different direction. If we know that that is normal and that is safe, we need to figure out how to do that on her that can't do it herself. Good? So this is a principle. We do not use side rails to keep somebody safe. Even if I put side rails up on that side of the bed and just turn her, she's still not going to be safe, even though there's side rails there. And her face is pressed into side rails, so she's probably not comfortable either. So side rails are not effective. We don't use them for safety. What we want to do instead is make sure that she's in the middle of the bed after the turn. So to do that, we're going to ask her, can you scoot toward me? And then we're going to roll you on your side. 1, 2, 3. So after the turn, she's in the middle of the bed. So the way that we do this, when you do it, when you roll yourself over, you do it all at once. You lift, scoot, and settle. Kind of all at once. When we do this on patients, we do it 2 steps, scoot and roll. Make sure you're behind the patient's behind. But the big thing you want to remember here is the patient has to be in the middle of the bed at all times. But it's the only safe place for the patient. You walk away from that patient, no matter what side they're on or their back, they have to be in the middle of the bed. Good? Patients must be in the middle of the bed at all times. So we just learned a whole nother principle. So they're not hard, are they? I know the first day you walked in, I told you we're going to learn all of them. You're like, but it's not hard. They're not hard. So where should the patients be? Middle of the bed at all times. Which way do you turn a patient? Towards you or away from you? Away. Okay. All right. Please remember that side rails do not keep people safe. They never have. They never will. Because a person's initial reaction when you confine them is to escape that confinement. Patients will go over the side rails. They'll go under the side rails. They'll go around them, and sometimes they'll go through them. Side rails kill patients. They're the #1 cause of asphyxiation of patients in the clinical setting. Yeah, they kill patients. And it's probably one of the worst things you'll ever see if you see a patient that tried to get under a side rail and was asphyxiated. It's horrible. So if somebody is needing side rails, that's not something that a CNA can determine. It's not something that a nurse can determine. There's a legal principle here called false imprisonment. You have the right to move about anywhere you want to because you're an adult. No one has the right to interfere with your right of self-determination, except there's only two people that can do that: law enforcement and a medical doctor. That's it. That's it. So if you're injuring somebody, law enforcement can temporarily detain you, but you got to go before a judge. And the judge is what's going to decide what happens to you, right? So law enforcement can decide to detain you. A medical doctor can decide that restraints are appropriate. Nurses can't do that. CNAs can't do that. Only law enforcement and medical doctors. Do you understand how important that is? So I've seen lots of situations here where the patient is very weak, very weak. And we know if they get up and walk around, they're probably going to fall. And that's a problem because we don't want patients falling. So the staff will say, okay, well, we're going to put the side rails up so that the patient doesn't fall. We don't want the patient to fall. It's all about their safety. We're going to put side rails up so they don't fall. Well, in medicine, we should be doing things that make patients better whenever possible, right? So if the patient's weak and we put them in bed and put the side rails up so they can't get up and walk around, does that do anything to make them better? In fact, if you restrict somebody's motion, what do you think that's going to do to their mobility? Make it worse. So we actually actively made them weaker. So all we did was keep ourselves from having to deal with the patient. It was our convenience. Had nothing to do with patient safety. It was our convenience. So that patient would be much better off if they were gotten out of bed periodically and walked to the bathroom with a staff member. So we're not restricting them, doesn't benefit them. Getting them up and walking helps strengthen them. So which one do you think is a better option? Walking them. Absolutely. So you're starting to see that side rails aren't exactly what people think they are out there. For the test, there will be no side rails. None. There will be no side rails. You cannot use them for safety. The patient always has to be in the middle of the bed. In a clinical setting, if we want to use side rails, we have to get a doctor's order. And that doctor has to physically come in and eyeball that patient, physically, hands-on, within 4 hours of giving you the order. And then the order has to be renewed every 24 hours. That's how serious this is. You do not have the legal right to interfere with another patient. So what we're doing now, instead of using side rails, man, when I first started in medicine, this was totally different. Side rails were up on every single bed when you left the bedside. You didn't walk away from a bed unless the side rails were up. We tied patients down like all the time. Restraints were normal. We just tied everybody up. You don't want to do what I'm going to tell you to do? You can do it anyway. I'm going to tell you now. So medicine was completely different back then. What changed was that patients got rights. That's crazy. You'd think they'd always have them. They didn't. I could do anything I wanted. Now they have rights. And one of their rights is to be free of restraints. So you have the right to say no. And I got to listen to that. I got to do foot care on you. No. I can't force you now. I used to be able to just tie you up and force you. Now I got to work through this. It's a good policy. It gives patients the respect and dignity that they need. Okay. But it's also made us come up with more creative ways of solving problems. So we can't rely on side rails for safety. Instead, we use sitters. If you go on to any hospital's website right now, you will see openings, job openings for sitters. They're also called patient safety attendants. So you'll, and all of our hospitals right now are hiring for them. It's a great way to get into the hospital until you get your CNA certification. And that way you can tell the nurses, hey, I got my CNA, I passed my test, woohoo. And they will slide you right into that CNA position. It is an easy way to get into the hospital. So if you want to work at a hospital, go apply as a patient safety attendant today, right now, and take that position. And then they'll move you to a CNA position with more pay once you get certified. Okay. Now, what do patient safety attendants do? Well, they take the place of the side rails. They sit at the patient's bedside. If the patient wants to get up, they make sure that the patient is safe. If the patient wants to roll over in bed and needs help, they help them. They're there to make sure that the patient remains safe without the need of restraints. And usually you can play on your phone or read a book or do those types of things while your patient is sleeping or, otherwise occupied. Not a bad job. It's not the pay grade. A little bit boring, but not a bad job if you want to read your textbook or do your homework and get paid for it. Right? Yeah, so lots of opportunities out there. Okay, so any questions on side rails? I have a whole lesson on this on page 94 and 95. You'll probably want to read that at some point. It gives you a very good overview on side rails. So there's one thing that I do want to talk to you about side rails real quick though. This is a hospital bed. This is the type of bed you would see in a acute care clinical setting, so a hospital setting. This right here is not a side rail. This is a positioning rail or what we call a half rail. Because a patient can still get out of bed. The end of the bed where people get in and out is not restricted. This is not a side rail. Now, if I lift this one up, this now becomes a side rail because I've restricted the patient's mobility. Most places don't even have these on the bed. They're not even there. So if we get an order from the doctor for side rails, we have to have maintenance come put the side rails on the bed. The reason for that is we can't trust people. We just can't. Because CNAs will say, well, the patient asked for the side rails. They feel safer with them. Really? Are you sure? Because that patient doesn't talk. This has been misused by CNAs and nurses all over the place. Because it is easier. It's way easier on a shift if all your patients are in bed. It's way easier. You don't have to do nearly as much. So for staff convenience, a lot of times places will pretend that patients asked for them. So because we can't trust you, we actually take these off the bed. We don't even give you that as an option. So if you get a restraint order from a doctor, usually maintenance has to come put them on the bed. One of the recent lawsuits that happened, there was a nursing home who their patients, the night shift, they had some dementia patients that would wander because with dementia, they don't always sleep at night. So they would wander and the staff didn't like that. So they would give everybody Benadryl and put them in beds with side rails. And one of the patients had an unfortunate incident. It came to light. They found out what they were doing and the nurses were like, oh, well, everybody has allergies. Really, it's that transparent that everybody can see through it. We have to be careful. Yes, we are there for a job, but we have to be careful not to forget that these are the patient's lives. They're not just like, they're not byproducts of what we do. They have lives, they have dignity. We need to respect them. We need to treat them like humans, not animals. Lawyers are looking for things like this. Just looking for things like this. On the way here, I heard a law advertisement on the radio today. Was a loved one injured in a nursing home? Please call us. No fee unless we win. They're just looking for opportunities. And trust me, the lawyers know all of these laws way better than you do. Way better than you do. So that's why this is important. We want to keep our patients safe. We want to do things ethically, but we also don't want to do things that's going to endanger the facility that would cause us to be party to a lawsuit. Okay. Otherwise, you might lose your job. Any questions on that? All right, so let's go back to page 98. This care plan says, position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So remember I said that the patient is not immobile. So for the test, we're actually going to ask them, can you scoot toward me? They can scoot, they just can't roll. So we're going to help with the rolling part. But you can actually move somebody 3 times your body weight. You can turn somebody in bed 3 times your body weight with no stress on you or them. 3 times your body weight without stressing you or them. It's all in the way that you do it. It's all in the process. So let me have somebody come lay down in bed. I'm going to make you very, very comfortable. You're not going to want to get up. It's so funny. Every class, there's always one designated patient. I don't know why. It's like, one person will, I know everybody looks at each other like, not me, not me. Oh, not me. Nose goes. Yeah. It is funny. I just need to start assigning patients here.
Okay. No, yeah, I'm tired.
Yeah.
Before 3:00.
So now if I want to turn her on her left side and I just walk up and try to turn her, it's going to be hard, because she's long. Yeah. How do you like manhandle them, right? Get them on their side. It's difficult. So to do this, you want to position the patient properly before the turn, and then the turn becomes easy. So there's 4 parts to this, and you're going to see me do this on her in just a second. But the way it goes is the furthest arm goes up, the closest arm goes over. Closest knee gets bent, furthest knee gets angled. So up, over, bent, angled. Okay, just remember that. Whichever side of the bed that I'm on, remember I'm turning her to the opposite side because I have to remain behind her behind. So because I'm turning her on her left side, I'm going to be on this side of the bed to do the skill. Remember, I have to turn her away from me. So I need a table for this because I need supplies. I'm going to need 3 pillows and a privacy blanket. Now, this patient, her cat, this person is fully clothed and holding onto all of her own body fluid. She has no open sores I need to worry about. So for the test, my patient right here, I don't need gloves for. In a clinical setting, if I've got somebody stuck in bed, they're probably in a patient gown, with not much on under it. Do I need gloves? Absolutely. Okay. So take the gift they give you for the test. This is way easier without gloves. Because we have to fold this pillow and push it under the patient. Your gloves are going to get stuck. This is easier without gloves. It's a gift they're giving you. If you want to wear gloves, go ahead. No problem. Here we go. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to turn you on your left side. Is that okay? I'm going to close the curtain. Let me go wash my hands and I'll be right back. I've washed my hands. So I'm going to start with a barrier. I'm not going to get my pillows yet because I got to put this on the table and I can't hold those pillows up next to my uniform. So we're going to start here. And then I'm going to get 3 pillows. and a privacy blanket. Okay. I'm going to spread this blanket out over the patient. Remember, I don't want to snap it or shake it. Okay, can you hold this for me? And I'm going to pull the sheet down underneath the blanket. Okay, scoot your whole body toward me. Can you guys see? Now just relax. Remember, up, over, bent, angled. Okay. So I'm going to take the furthest arm, put it up over her head. Closest arm is going to cross her chest. Closest knee is going to bend and put the foot flat on the bed. And the furthest leg is going to angle out. So now she's like half on her side, and I didn't have to push her or prod her or anything like that. So now it's very simple. I put a hand on her shoulder and one on her hip. And just roll her on the side. See how that's no stress on her? Doesn't hurt her at all. Doesn't hurt me either. But she's not going to stay there because remember, gravity is going to pull her onto her back. So I've got to use some pillows to prop her there. The way we're going to do this is take a pillow and put it up against her back, kind of like a ski slope. So it's at an angle. And I'm going to press this edge underneath the patient here. So I'm going to push down and then forward. I can't just go forward because her back is down. So down and then under. So I'm going to push this down and then under. I'm going to do the same thing with this edge. I'm going to roll it down and under. Stretchy strut tops. She's still a little too close to the edge. So I'm going to bring her back. Let's get a little bit closer to me. It's over. It's not. I'm going to angle this one. Okay, that's going to be a little better. So now I'm going to turn on her side. That's during the test, if you look at the patient, you see they're a little too close to the edge, make sure you address it. Don't think to yourself, oh, the evaluator doesn't see it. They see it. So I'm going to put this up against the back and press that edge underneath the patient. If they've got really stretchy scrub tops on, you may have to kind of hold that top out of the way, because otherwise it'll kind of get caught on the pillow. So we're going to push this underneath the patient as well. So it's going to make a roll. See how it made a roll behind the patient? This is the hard pillow. This one's hard to do. You'll have to practice that. This one is going to go between her legs, but specifically between the knees and the ankles. So she looks a little too straight here. I'm just going to bring her legs forward just a little bit. That looks better. I'm going to lift her leg up and put this between her legs, between the knees and the ankles, so those bony areas don't rub together. This pillow is going to go here underneath her top arm. If you notice her arm kind of sinks down here, this puts a lot of pressure on her upper back and into her neck, can cause muscle spasms and headaches. So if I lift her arm up and put this pillow here to support her shoulder and upper arm and her forearm, this relieves a lot of that pressure. Now the pillow under her head is under that bottom shoulder. It's kind of scrunching it up on the bottom. So I'm going to lift her head up and adjust that pillow so it's only under her head and neck. So lift her head up. Just put that one underneath. How's that? Okay. So your patient should be very comfortable at the end of this. Their arms should be supported, their head and neck should be supported, their legs should be separated, and their back should be in alignment. So once you've got the patient all settled, then you'll bring the sheet back up. We're going to take that privacy blanket away. And anything we take off the bed, we're going to roll up in a ball so that the trailing edges don't contaminate anything. And we'll put this directly into dirty linen. Now I need to give her her call light, but I can't just drop it back here. Here's your call light. If you need anything, let me know, because it's too far from her. This actually has to be placed in her hand, but it's fastened over here. And for the state test, it will be fastened on the wrong side of the bed as well. What they're seeing is, are you going to put this over her neck? So you want to put it like this. Are you comfortable? Is there anything else I can get for you on here? Would you like a magazine, which makes no sense, but we're going to offer it for the test anyway? Okay. So I'm going to open the curtain. This is going to get thrown away. That's away. My environment's clean. There's nothing else I really think I have to do. I'm going to go wash my hands, tell the evaluator my skill is done. Good. Questions? Up, over, knee bent, knee angled. Up, over, bent, angled. Told you I was gonna make you comfy.
She's like, gonna say you can cut the light.
I was gonna say,
Yeah.
I was gonna say.
She's like, you don't have to take them away.
Did you have to take the break?
Okay.
Why in clinical settings, do they give a pillow that basically is going to have your head and neck on the.
Oh, I know. They're so flat.
Pancake pillow.
Yeah, they're so flat.
Yeah, they're the most uncomfortable pillow
Mhm.
ever. It's like, why bother giving them?
Yeah. All right. So